And just to advise members, as always, the committee meeting will be recorded and broadcast throughout Parliament buildings and also online. I'll just wait, people coming in. Okay, just to advise members and those in the public gallery that everybody's very welcome to use mobile devices as long as they're in airplane mode and all devices are muted. You can connect to the Assembly Wi-Fi and the password details are available there on the gallery rules on the seats. It's not permitted to take photographs or record any of them. So just moving on then, apologies. Received apologies from Noel McAllister. I think that's it, everybody else is here. Chair's business. Can I just thank all who attended the committee's hugely valuable meeting on respite services on Tuesday in Parliament buildings. Can we, on behalf of the committee, especially thank the mothers of those children with complex needs who provided very emotional and difficult testimonies of their lived experiences of caring for their children on a daily basis when respite services are not available. So thank you all for that, and you're very welcome to today's meeting. Can I thank those members who were able to attend that event and for taking the time to listen to the challenges and the difficulties facing the families. Undoubtedly this exercise is going to be hugely beneficial to the committee today and further when we explore this issue, including today's briefing with the department. Can I seek members' agreement then to defer the research briefing until next week? Happy enough with that? Yep. Okay, thank you. So moving on then to item number 3, draft minutes. Can I refer members to the draft minutes of the meeting held on the 6th of March 2025, page 6. Everybody content? Thank you. Matters arising. So the committee agreed a motion on core grant funding. So a copy of the draft committee motion is in our table packet, page 3. The motion was also emailed to everybody yesterday afternoon. So can I seek members' views on it? I was just going to suggest myself one slight change when it comes to the wording of the funding. So notes the current level. I think we should put of core grant funding. So the word, I think we should put the levels of core grant funding in there falls significantly short of what is required, just to make it clear that we're talking about the core grant fund. Yep. Any other changes or any? Go ahead, Al.
Yeah, I just thought that maybe we were doing the sector a disservice by just sort of pointing the motion towards the Department of Health, and I think that maybe we should have broadened it and copied correspondence to other relevant executive departments and even each member of the executive, but because I think it really goes, the issue goes broader than simply asking the Minister of Health to find extra money.
Well, I mean, we're the Health Committee. The Minister allocates the funding. I mean, I think it was the committee's view last week that given the nature of the groups and the work that they do, that we as a committee should ask our Minister to find some additional money to help and support those other groups that are doing great work. And actually they would help, additional money for these groups helps the Minister in his shift left, because these groups are doing work to the very left with regard to keeping people safe and out and ultimately out of hospital.
Yeah, but are we living in the real world when we expect the Minister to pull like a rabbit out of the hat here? More funding. How much more funding does he need? If what he's allocated at the moment, if that was doubled, that still wouldn't give every group what they're looking for. And I would have thought part of our role here, and we keep talking about it, is to support the Minister. I know we're here to scrutinise the health department and so forth, but we also have a role, I think, to support the Minister. And if the Minister is experiencing difficulties in getting funding from the executive, I would have thought there's nothing wrong with us supporting him in that effort.
I'm going to call Dan, and I'm going to make one point. I mean, certainly we should be supporting the Minister when we think we should be supporting him, but that doesn't stop us from either criticising him when we think, as individuals or a committee, we think that's warranted. I mean, I will make the point that on our next subject, when we're talking about respite care, I looked back at the Minister's evidence when we were questioning him about the additional 2 million and the additional 11 million. His actual words were, finding the money was easy. It was finding the staff, etc. after that. That was the difficult thing. So, I mean, all I can say is that when he has said that, particularly about 13 million within his own budget, finding, in his words, finding the money was easy, we're asking him for a very small amount of money. Diane?
I do agree with you. I think that this is the Health Committee, our Minister is the Health Minister, and these are core health funds in the community and voluntary sector. And the actual amount of money represents something around 0.02% of the overall health budget. So this is a very small amount of money in next year's £8.4 billion allocation to the Department of Health. So I think that your amendment around making sure that it is the core grant funding is absolutely correct, and I think it's fine, and scrutiny and questions are always useful.
Danny?
Yeah, just a couple of things that I agree completely with Dan, and I think it has to be sustaining community and voluntary services in the long term. But I'd like to see if we could put in something that we could explore the impact assessments that have been made to the used to make these decisions. But Dan was saying it is 1.8 million out of an 8.4 million
billion
budget. But that's down from 3.6 million where it was 2 years ago. So it was halved 2 years ago.
Yes.
And we're now operating on the 50% model effectively. But if we could see the impact assessments, I think if that could be in there as well. I know that's a lot to put into one motion. Thank you.
Linda?
Very quick point, because I know we have a lot on today. I think that Danny's point around the impact assessments is really, really important, because we're not asking for money to be through out to organisations here. There needs to be accountability on how they're spending it, but the impact of how they spend it and the impact if they don't. The impact of how the health department funds them, and then the impact if they don't. I think we really do need to understand that. That's the important part of this, because at the end of the day, that's what it's about. It's about the impact it has for the wider public out there and the people that those organisations are serving.
Colin?
Thank you, Chair. I mean, notwithstanding the obvious position as a member of the opposition, I don't see this as Department of Health. I see this as the executive. It makes its decision as a group where money goes, and then individual ministers decide where it goes. But to me, it's one system that's letting these people down. But I think I did raise that point, which has been passed through to Keith, about maybe trying to understand the impact of what the funding of the groups, specifically the groups that did apply, those that did get funding, what they're not doing, because that will result in longer waiting lists at GPs. They'll have to go on the lists for physios. They'll have to go on for counselling services. We're not shifting them left. We're just shifting them. It's just rearranging the furniture around. And I think but I think there maybe is enough room in what's there to be able to tackle that, because we do reference that. We recognise the vital role that they play, and that allows us the opportunity to say, well, we know that they play a good part, but if they're not funded, then they're not going to get to play that part. But and you could end up just keep adding and adding and adding and adding to it. I'm sure we'll all use our parliamentary linguistic skills to be able to get what we need wound into it.
So, notwithstanding all the comments and Alan's point of view, we're happy enough that we add in the word core grant funding. We try and find a way of words that kind of identifies the points that Colin and Danny are making, and proceed.
I would like, because you'll not be surprised, I'd wish to record my dissatisfaction that we are doing the groups a disservice by the wording that we're using, that we're not going broad enough. I absolutely support the community groups getting the funding that they need. I recognise the work that they do, the invaluable work that they do. But I just think on this occasion, we're doing them a slight disservice in the way we worded this. So if I could just have that recorded.
Yep. Sure. Those points will be made during the debate as well. So we'll just move on then. So where are we at? So also members at last week. So anyway, once Keith adds those words, I mean, I'm suggesting he sends out the final word, and then we'll submit the motion to the business office. Moving on then, remind members, last week's committee meeting, we as a committee requested the Minister and the Trust appear before us to answer questions on the media announcement last week on the potential relocation of patients from the acute mental hospital and patient centre in Belfast. And we all seen the media reports about mould and flooding and whatnot. So we have been advised, those correspondence came, obviously the Minister this week is in America. There was an option to have the Trust and officials potentially with us today. As Chair said that the committee had asked for the Minister and the Trust, so Keith went back to the Minister to say, or the Department to say we wanted the Minister. So we've been advised since then that the Minister believes it would be more appropriate for the Trust to brief the committee, as it will be able to answer all the questions that members may have. So I'm throwing that open to members if they have any comments on it. Dan?
That's really disappointing. Really, really disappointing. The Trusts are accountable to the Minister, and the Minister is ultimately accountable for what happens. And it is really disappointing that the Minister is choosing to say you can have the Trusts but not me. I do think that there are questions on the overall performance of the Belfast Trust in relation to the new builds, and have been working for many months looking at those figures and so on. And the issues around the acute mental health building in the City Hospital, those have actually been known for quite a long time. The extent of them has only become apparent because they have a review. My understanding that they're about to get the results of that review, and we should know that, and the Minister should take responsibility. That is disappointing.
Okay, any other call?
I would go support Diane and go further and just go back and say no, we want the Minister here with the Trust officials, because if there's one thing that just galls is when a Minister stand up and say, sorry, those tens or hundreds of millions of pounds of public money that we spend by giving it to somebody else to spend it, now we're not responsible for them. Yes, you are. You're the Minister, it's your department, you hand the money to the Trusts. And likewise, that could be the Education Minister gives the money to AEA or whoever, or communities to housing, whatever it is. If it's public money, we're supposed to hold them to account. And if there's this buffer, because, you know, the only person that's ultimately responsible to us is the Minister. And I think all Ministers should take that responsibility very serious. But sending in the paid staff to go in and take the wrath just doesn't feel fair or right.
Okay. Colin's made a proposal that we go back and write to the department, say we want the Minister here.
Happy to
With the
say,
Trusts,
yeah.
I'm content with that, yeah.
Okay, happy enough. Okay, so moving on then, number 5 on our agenda, which is a departmental oral briefing on respite services, short breaks. So can I refer members to tab 5 of our pack? This includes a departmental briefing paper at page 18, summary of the Trust's in-year plans at page 24, and also a departmental response to queries on the business case for 13 million for respite services. That's at page 49. So can I just welcome Nigel Chambers, Head of Learning, Disability and Autism from the Department of Health, Maurice Leeson, Programme Manager, Partnerships, Emotional Health and Wellbeing, CAMS and Disability within the Department of Health, Lynn Priest, Director of Children's Services, South Eastern Health and Social Care Trust, and Maura Dargan, Director of Children's Services within the Northern Health and Social Care Trust. So can I just remind everybody, we have 1 hour for this. I'm going to hand over to yourselves. Have you worked out maybe just...
Have an opening
okay,
statement.
go ahead, Morris.
Chair, thank you very much. Good afternoon, and thank you for the opportunity to provide the committee with an update on our work to improve services for children with disabilities, their families and carers. Today Nigel and I are joined by senior colleagues from our trust, Maura and Lynn, to provide a greater insight of the challenges at a local level and the progress that has been made in recent months. From the outset, we need to be clear that we can't respond to queries on individual placements or the circumstances of individual families in this session. What we can discuss is our understanding of the issues, the strategic response and the plan to utilise the additional funding to maximum effect. We provided you with a written briefing in advance of today's meeting, and I've been assured this has arrived with you in time and for today's discussion. As outlined in the paper, there's a growing population of children with disabilities known to social services in Northern Ireland. In 2020, this figure was approximately 4,500, largely comprising of children with learning disability or autism. Now, today that figure is more than 5,600 children with disabilities that are known to social services. This growth can be partly attributed to population changes, but we must acknowledge that the reality that more children are slipping into the social care sector. The growth in population known to services has been accompanied by an increasing complexity of need. And to give you an example, we've gone from 422 children with a disability looked after in March 2019 to 556 children with a disability looked after in March 24. It is accurate to say that services have been stretched significantly. There are clear demand capacity gaps for residential and short break services and growing levels of unmet need. Today there are 81 children with disabilities assessed as being on the edge of care, and that number has increased since the families here with us today told their stories in September last year. Nearly 300 children are on waiting lists for residential short breaks. That number has not decreased in recent months. Committee will be aware that over half of short break beds have been repurposed to provide full residential placements for children with disabilities. Other beds have been impacted by gaps in our workforce and are operating on a reduced basis. A key message we want to communicate today is that short breaks for children with disabilities are fragile. They're fragile because of the volume of children in need of a service. They are fragile because of the level of risk that families and professionals are managing within homes, and they're fragile because of the lack of suitable residential placements. This context, a robust evidence base in the views of families and professionals, has guided us in the development of a framework for children with disabilities. It sets out our strategic approach to address key pressure points within health and social care, and particularly to improve our early offer of help, to develop additional effective short breaks and short break fostering, to rethink our approach to residential provision and out-of-home placements, and to get transitions right. The framework is the agreed strategic position of all of us, the Trust and the Department. As set out in the paper, we've established a dedicated work stream to implement the framework as part of the Strategic Reform Programme for Children's Services. Significant progress has been made to better understand need and capacity, to improve regional consistency, to develop options for recruitment and scale up of specialist mental health services for children with learning disabilities. In the context of today's discussion, needs assessments have been undertaken for short breaks in residential care. Significant investment is needed to make the current level of need, and this will need to increase in line with population projections. Work is currently underway to cost the full implementation of the framework, including the development of costed options for residential and short break services. We're very conscious of the challenges presented by workforce issues and the vacancy rates in the Trust and the knock-on effect this has in terms of unallocated cases. The additional funding announced in October last year accelerates this work and provides a stronger foundation for further investment over a sustained period. 13.1 million was allocated on a recurrent basis to improve residential and short breaks, while rapidly expanding family, therapeutic and behavioural supports in the community. Within the financial year, up to 2 million was allocated, with 1.37 million utilised. It is important to note that the Trust's ability to spend is impacted by central department financial processes, availability of buildings and workforce. In terms of progress to date, trusts have proceeded at risk to deliver measurable improvements to the service and have plans in place to improve short breaks and residential capacity. And to give some examples, Southern Trust and Western Trust have increased short breaks provision through expanding capacity in existing units and recovery of lost beds. Northern Trust have plans in place to recover a short breaks unit in the coming months, with the intention of scaling up capacity to provide 5-6 beds on a phased basis throughout the year. Committee will note it has been challenging to remobilise the service within the financial year, partly due to a regulation issue that has been resolved, and it is important to stress that the Department challenged Trusts to develop creative responses to the challenges faced. The plans in place for Northern Trust are novel as they involve a different approach to transitions in adult services that potentially could be scaled up on a regional basis. South Eastern Trust have clear plans to reinstate short breaks provision in Lindsay House by establishing residential provision in Redwood, a unit that committee members have been interested in and have expressed that interest. It is important to note that Lindsay House is a shared facility with Belfast, and therefore the impact of this work will be significant in scale. Secondly, this is an example of the challenges faced by trusts across the region. The remobilisation of this service can only be achieved by moving looked after children to other sites. This requires careful planning, and delay in one part of the process can significantly stall the entire exercise. Both Lynn and Maura can talk about this very challenge, and which can only be fully remedied by increased residential provision. Belfast Trust intends to reopen Willow Lodge before the summer. Increasing residential capacity and therefore reducing the risk of short break beds will need to be repurposed in the future. Within this financial year, there has been expansion of in-reach services and scale-up of existing contracts with voluntary and community sector. Across the region, committee members will note plans to develop fostering short breaks, also known as Share the Care. This model has already been established in Northern and Southern Trusts and is now recognised as a way of providing families greater choice and flexibility on the types of support they can access. To be clear, it is not the intention to replace residential short breaks with a fostering service, but it is expected that a greater range of supports will reduce the upward pressure on the residential service. Lastly, the Department and Trust have continued to engage with the families profiled by BBC Spotlight, as well as engagement with the National Autistic Society and the Children's Law Centre as advocates. We are fully aware of the level of risk that is being managed in the family home, and several complaints have been raised on communication. These issues were raised with the Minister last week, and we intend to convene a meeting of families, chief executives and directors from the Trust in the coming weeks. In conclusion, challenges faced by families in health and social care are significant. Through the ongoing work progress at a strategic level has provided a robust understanding of the nature and scale of the challenges. We have a consensus in the way forward, and the additional funding allocated has accelerated our progress. However, it will be necessary to make further investments, otherwise the progress over the next 12 months could be lost. I'll pause here and happy to take questions and comments. In terms of questions in Belfast, Southern and Western Trust, Nigel and I will do our best to answer questions with the committee, but we may need to take some of those questions away, and hopefully the committee will be understanding of that. Thank you for your patience.
Thank you. So, in your paper that you sent to us, I mean, you referenced 877 unallocated cases across the trusts. You also mentioned in the paper 287. Morris, I think when you were talking there, you said it's now over 300 children with disabilities across all trusts and waiting lists for residential short breaks. So that's 1,164 children that either haven't been allocated social worker or on a waiting list for a residential short break. So can you maybe give an indication of whether those numbers are evenly spread across the trusts, or are there any trusts with significantly higher numbers than others? And secondly, what's been done to address that situation, and when do you expect to see progress significantly reducing those figures?
Well, if I can comment and say that whilst families are waiting for a short break, there will be other things happening in the meantime. There'll be constant contact with social services, and there may well be other types of service that are also in place for those families. In terms of how they're spread, the Northern Trust is the only trust that's shown no unallocated, and the others range from 34 through to 499.
Just to add as well, a committee 2 weeks ago used it to ask for further information in writing, so we're in the process of putting that together. In terms of unallocated cases, Dan, I think you raised this question about the number of allocated cases, the breakdown of that, and what types of supports are being provided to families and what that looks like. So we're hopeful that'll be with you probably within the next week in terms of that greater written detail.
Okay. And in terms of my second point, because I'm not quite sure it was answered, about when do we see those figures coming down? No, it's okay getting the figures and allocating them to a geographical location, but what we're interested here is the work to bring them down.
Okay, well, it would be useful, I suppose. So part of the piece around unallocated cases is that there is a variance in terms of vacancy rates across our children's disability teams. Now, at the time that the decision was made to allocate additional funding in October, the vacancy rates of the children's disability teams were close to 60% in some trusts, and as per what we provided within the paper, those vacancy rates have dropped to, I think, upwards of around 30%, but that's still significant. Those vacancy rates then have a direct impact then in terms of unallocated cases, And Lynn, or I suppose that's a challenge that you're both trying to navigate in terms of recruitment and addressing the waiting lists.
Yes, if I could answer that a bit more broadly. The South Eastern Trust is one of the trusts that has the higher number of unallocated cases across the region. We have a plan in place to reduce that number quite significantly, and we're hoping to get that down by November 2025. It is dependent on an available workforce. We all know that there are problems within a social work workforce, but within a children's disability service, the workforce might not always need to be social work, but it might need to be social work led. So within the context of a skills mix, we're hoping to recruit staff that will be able to support families in a different way, a much more flexible way. It's important to note that we have, as have other trusts, taken account of the numbers of children that are on their waiting lists and what their needs actually are. There are robust governance arrangements in place to manage those cases, and I can say confidently that the children in the South Eastern Trust that are on the waiting list for social work service are children with those lower level support needs. Those children are being seen by occupational therapists, by speech and language therapists, by CDC clinics, by CCN nurses. So there are a range of other professionals involved with those children. It's not that the children are waiting on a service and not being seen by anybody. It's just to make that point a bit clearer.
Okay. So, I mean, you'll be aware that some of the family members from Tara Mills Spotlight, I'm Not Okay, or something behind you are here to hear evidence today. So that was a very difficult programme for anybody to watch. I mean, I found it difficult watching it from the comfort of my own living room. You'll also be aware that the committee met informally with the families on Tuesday of this week, 5 months on from the programme being broadcast. I have to be honest, I consider myself a hardened politician, but it was one of the most emotional and difficult engagements I've had in 25 years, having to listen to those families and what they're going through and listen to them through tears about the issues that they're dealing with as families. But worse than that was actually when they listening to them detailing that when they quite rightly reach out, ask for help, ask for relief, ask for respite, it's not there. Even more disappointing in that is that they're saying that nothing has changed in the 5 months since their plight was highlighted. So, Maurice, you talked about engagement issues, communication issues. You know, some of them were detailing that they've been let down. You know, they were promised respite, it was cancelled. You know, there was just a litany of things that, as a politician, I mean, I felt shame. So I think we should all feel kind of a collective shame in relation to what we have allowed to happen. But obviously, I mean, the committee listened to them. We have given those families a commitment that we don't intend to let this issue go, that we, when our question you today, are going to try and get answers as to how we collectively can make this situation better. So the department was given £2 million for this year. It was also given 11 million over the next 2 to 3 years recurring funding. And Maurice, you detailed some of the things that it's for, but I mean, you clearly identified respite, residential, short breaks, services. So in relation to that money, can you tell me how the department is ensuring that respite funding is not simply being allocated to, and I have to choose my words wisely here, some of the easier to implement systems and services, but that money is actually also being prioritised for those children with complex needs and those families with complex needs.
Yeah. What we're trying to do, I think, is a quite complex arrangement whereby we're both wanting to attend to the immediate and very pressing needs of families like the Spotlight families, and also to ensure that we have in place the type of arrangements that will ensure that people are supported at an earlier stage and are not put in a position where they end up needing a more complex service because we've not been able to respond to their needs. That's quite a complex thing to do, and I think on that journey we will be open to criticism because we won't always get that balance right, but that's what we're setting out to do, is to ensure that we do attend to both.
But
I mean, in
5 months,
terms,
I'm sorry to interrupt you, Morris.
Sorry.
5 months on, I would like to know, you're telling me you're doing 2 things, which is great, and we would expect you to be doing 2 things, but in regard to the second thing about dealing with the children with the very complex need, I would like a specific answer to the question of what has happened in the 5 months to address those, and what is going to happen moving forward.
Okay, I suppose a combined answer from both of us. When trusts, the department, the RQIA and PHA met in October, the question is what could be done? What could be done in days and weeks and months, not months and years? And there was recognition aligned to the Children's Disability Framework that we did need to take that approach of attending to the immediate extreme pressures of today, but also providing a much greater level of support within the family home to a much larger population that are at lower levels of need at the moment, but could require short breaks in the future. Throughout that discussion, it became clear that the proposals around short breaks and residential were always going to be proposals that would run into the next financial year. So in terms of family therapeutic and behavioural support, yes, these could be viewed as things that look good on a spreadsheet, that you can scale up quite quickly, you can talk about hundreds of families benefiting from, and that we rely heavily on the VCS in terms of using existing contracts and adding additional funding to those. But that is, in terms of what could be achieved within the financial year, that is where most of the activity has happened. But there have been nominal increases to the short break service, both in terms of Southern Trust, expanding day provision in 2 of their facilities, and Western Trust in terms of recovering lost beds in Rosebud Cottage. Within the next financial year, what we set out, you can see across the other trusts then, the residential and respite components start to kick in from April onwards. Now the real challenge around this, I suppose, looking at the issue that was profiled in Spotlight, we have 16 children that currently live in 26 short breaks beds out of the 45 that are commissioned in Northern Ireland. You could have taken all of that funding, the £13 million recurrent, and bought residential placements for those 16 children. The problem is you have 81 children on the edge of care. That would have inevitably slipped into becoming looked after, and the beds that you had lost or recovered, you would have simply lost again over time. So there was a necessity for us to look at this in terms of the family, behavioural and therapeutic piece, whilst also scaling up what can be done within respite and residential. And in Morris's opening remarks and what you can see within the detail of the plans that have been provided to you, the remobilisation of short breaks can only really be achieved at present by moving children around who currently live in those beds. So moving children from A to B to C to get A back again. And those plans are quite fragile in that a lot of moving parts have to move the correct way at the correct time. And as Morris opened, if anything stalls in that process, it can stall all of it. Lynn and Maura will be able to talk to that in terms of their plans around Redwood and Lindsay House, and in terms of Whitehaven within Northern Trust as well. But those are 2 examples where we're needing to move children that have very complex needs into full-time placements, which take time to get right in terms of compatibility, environments, in terms of workforce, in order to recover the short breaks beds that have been lost. So I can understand the frustration around it. Certainly as I watched the documentary, like yourself, shocked, and I think collectively at this table we do feel shame. We feel shame that we work in a system where demand has outstripped supply for a significant period of time. And within that environment, families have to paint the very worst picture of how things are. And when I've engaged with the families behind me and wider than that, it really shocks me that the gap in services has brought families to talking about their children in a negative light instead of in pride and the things that they like doing with them. But that's the system that we currently have that we're trying to work our way out of, and that will take time in terms of the residential and respite piece.
So can I gauge from what you're saying that in the financial year coming from April that there will be substantive difference for the plans that you are putting in place which will have an impact on these particular families?
I don't want to speak too much to your plans, but in terms of South East and Northern, from April onwards, really, you can see expansion of existing facilities and recovery of lost beds.
Yeah, I'll answer that. So in terms of the South Eastern Trust, yes, we do have a plan to recover some of the short breaks beds. We do have a current short break service, albeit it is very limited, and it's in Greenhill in Newcastle. We've been able to offer families who are in most critical need some limited overnights there, but we need to build on that capacity. In order to build on that capacity, we are opening Redwood, which is our intention is to open Redwood in September 2025. I appreciate that is quite a time frame, but we do need to do some work within Redwood to make it comply with fire regulations and OT recommendations. So that work is starting in the next couple of months, and we're hoping to get that off the ground. When that is open, then we will be able to reopen Lindsay House, which is a substantial availability for children across Belfast and the South Eastern Trust, and hopefully through that we'll be able to recover the beds that we have lost through long-term placements. Redwood, if I can just go on and mention that, if that's okay, if you're happy enough. So we're always dependent on, all of these things are dependent on the availability of appropriate workforce and a highly skilled workforce. That has been difficult to achieve across all of the trusts. So we have had a recruitment day for Redwood, and I am pleased to say that we have successfully filled all of the posts that we need. So it's our intention to bring those staff in at an earlier time to ensure that they're trained, that they have the appropriate skills, and that they have the ability to care for the children that we're asking them to look after, because it's quite complex. So our plan will be to recover short breaks through the opening of Redwood, but as Nigel said, all of those plans are very fragile, and it requires all of those things to align in the right way to be able to deliver that in the time frame that we want. I have said that to the families, and I have said to a number of families, that a lot of our plans are dependent on the number of children that are on the edge of care. In the South Eastern Trust we've 13, and at any one time any one of those families could need a higher level of support than we're currently offering or we're able to deliver, and that in itself might cause a bit of a disruption to the plans that we have in place.
Or do you want to add?
Yeah, similarly, I suppose one of our units is Whitehaven, that I think, Donnie, you'll be familiar with, that offers between 5 to 6 respite beds 7 days a week. And Whitehaven continued to provide respite through COVID to its full extent, which was an achievement in itself. But unfortunately, because of the full-time care needs of a number of young people, that unit has been closed to short breaks for some time now. Part of the plan that we had hoped to implement in year and into next year was about the move on of other young people in another unit in Eden View that would allow us to move these young people into Eden View, which would inevitably open Whitehaven back up again for short breaks. The plan for those young people was about their move on into their forever home in advance of their 18th birthday. But because of regulatory issues, that was a challenge for us. But thankfully, we have managed to overcome that regulatory issue, so we are able to now execute those plans. We've engaged Positive Futures to be able to deliver on those. They are actively recruiting for one of the young boys, and for the other family they will require to purchase a home. So one of the plans is earmarked for around the summertime, and the other plan is probably more close to the autumn because of the purchase of a building. But that would mean that from the summer we will begin to open up a level of respite within Whitehaven, and by the autumn we should be fully functioning again in Whitehaven. Eden View is a unit that provides full-time care and also respite. It's nearly like divided in two, and it has not provided respite for a good number of years actually. It was a unit that as a trust we took over from one of the voluntary organisations, and for staffing reasons we haven't been able to open the respite side of that provision. So like Lynn, we're in the midst of a very robust and aggressive recruitment campaign. There is a lot of background work underway, and we will be complying kind of probably with the same approach that Lynn has taken to recruit from March in the next couple of weeks. But with the recruitment of that, we're anticipating into the summer before we would have staff in, trained and skilled to be able to deliver the care. So a bit like Lynn, we're working with what we know, but we still have, like Lynn's Trust and others, a number of families who are in a very vulnerable and fragile state, and we continue to support them to the best of our ability. But any move in that could damage our plans. Setting aside the residential aspect, there was reference to share the care, which is the fostering option for families, which doesn't meet the needs of the young people who present with very challenging behaviours, but it does provide a really good service for those children who can be managed within a family environment. And within the Northern Trust, we have had, like the Southern, we've had a model that has been in existence for well over a decade, and we have 110 carers that provide very regular respite to 88 children. So there are some really good things happening and that are in place. I suppose the money and the investment that we have will help do, as Nigel has said, around the family support, the therapeutic and behavioural engagement that we need for these young people when they are at home and when they are with carers, and obviously building as much as we can the short breaks to be able to sustain as many families as possible, and avoiding the full-time care options that need to be there for a percentage of our young people. But this is a moving feast, and it is day to day managing. You mentioned about communications, and I'm not even sure what that's about, but sometimes it's every day something changes that creates a different response, and sometimes communication can be impacted by that. But the staff and everybody are working to the best of their ability to make good use of the investments that have been made. There will need to be further investment if we are going to meet the current demand and future demand, without a doubt.
Okay, and thank you for that. And I'm conscious. Sorry, Maurice, go ahead.
I was just going to say that we've tried to be very, very careful with dates, because we're very conscious of the fact that when we offer updates, it's frustrating for yourselves, very, very frustrating for the families. I can't imagine if we can't meet those dates. So we've tried to be as careful as we can and being realistic and communicating this will happen if the following things happen, and just being very careful about that.
And I mean, obviously that's correct, but we do want to see urgency, and the families want hope, and they want to hear that there is hope and that it's not too far down the track. I'm conscious I'm not going to hog the meeting, so I'm going to hand over to other members now. In terms of the communication issue, that was one of the things that was very disappointing to hear from families who had opened their doors to the TV documentary, and that we all witnessed that even despite that, and 5 months on, they did feel that their voices weren't being heard, that people weren't listening to them. I know since they've been to the Minister last week, there have been a number of meetings organised. I mean, that's disappointing in itself, that it required a meeting with the Minister, that it required a meeting with the Assembly, it required this for action. So, I mean, this committee will be seeking regular updates on this issue overall, but also particularly with regard to those children with very severe needs. And I mean, we certainly won't want to hear some of the things that we heard on Tuesday when we're receiving those regular updates. Orlia?
Yep, I'll try and be quick, because I know we haven't got much longer left in this session, and everyone else needs to get in. So just to repeat some of the remarks that the Chair mentioned, when we done the informal session with the families the other day, I was really frustrated. I think we all felt heartbroken listening to each of them telling their stories, but what annoyed me was that It was they were having to open up their raw emotion, hurt, pain over the most precious people in their lives, their children. They were having to open it up in a room of MLAs, strangers, people they don't know, after going public in the BBC Spotlight programme, and they're still having to open that raw pain and share it with the public, which must be a really, really devastating thing to do. And the key things for me are, we've heard about there's plans in place, and there's beds that are hopefully opening up over the next few months. Although it sounds very low in number, I know there's a workforce element to that, of course. But the issue that the families haven't seen any difference, and we'll maybe not mention individual families because we can't go into individual cases, but let's just use the example of every family who has, where you're dealing with a very, very complex case, a very, very complex child. So each family in each of the 5 trusts, why would those families not be feeling that there's no difference since these announcements? Because the announcements were made in response to the crisis of how these families are living. So I get all the early intervention stuff. We spoke about this the other day, and no one's going to argue against that. It's very, very important to put all that infrastructure in place, so you're planning for the future and for all the other children that are coming through the system. But the crisis point has passed for the families who have brought this issue to the fore and to the media and to the public. So we're 5 months on, £2 million being invested. There's another 13 million coming, and I just am not convinced that even with the next financial year that you're going to have capacity for all of those complex cases. And that was the reason for the Minister responding in the way that he did with this investment.
I could just come in on that. Thank you. So within our own trust, I've had the opportunity to meet and communicate our plans with the families. What we have acknowledged is that some of the things that we are putting in place, certainly in year, because it's part of the early intervention work, is not going to address their concerns and their living situation now. What I have been able to articulate is what our plans are in the future. We have been able to offer, we do have some limited overnight short breaks in Greenhill, as I mentioned earlier, and we have been able to offer that. I do appreciate our communication could be better with the families. I absolutely acknowledge that. And sometimes when that communication issue arises, it's because we've had to maybe stand down or cancel short breaks that we have planned at very short notice. I can appreciate that's very frustrating for families, and very, very difficult when they have been waiting on a short break to be offered and be delivered. I know that our staff on the ground are trying to find a solution that will work, that maybe involves outreach, and I speak for all trusts in trying to find solutions very quickly, and that is very difficult. I have given a commitment that I will continue to engage with all of the families and talk to them on a regular basis about what we are able to put in place for them. I have communicated what our plans are, and hopefully we will be able to offer a solution through those more flexible services, because we do try and be as flexible as we can to be able to respond to the need on the day.
Just to add that would be applicable across the region then. So in terms of what was able to be scaled up within the financial year, it is the type of supports where those 81 families who are on edge of care, they're past the point of being able to benefit from those interventions. However, it's important to stress that through this investment and future investment, we do need to have much more robust multidisciplinary behavioural support in the community. Respite services in terms of behavioural challenge are important, but they do not provide the therapeutic support that's needed to help a young person understand their emotion and communicate that in a way that doesn't result in behavioural challenge. And that is where social work and social care in isolation in a short breaks unit wouldn't be able to deliver that. And that is the necessity then as to why we need to grow, and why the proposals that we've set out in the plans include greater use of psychology, learning disability nursing, and support within the home. Because unless we actually be able to work with the young person in terms of their current level of need, their communication and their behaviour, simply having short breaks will just move behaviour somewhere else.
No,
But it does help families. It's the crucial part of the service. I'm not saying it's not necessary.
No, 100%, and I appreciate your feedback, but I'll finish with this. I think that what needs to happen is that clearly there still has, with all the communication that's taken place, there's still a breakdown, because otherwise we wouldn't have witnessed what we witnessed with the families the other day, basically. So there's a breakdown in communication somewhere, and I think going forward, for all the goodwill in the world in terms of what needs to happen and what should happen, and what the right thing to do is for going forward in the years to come, the families, those 81 families that you're speaking about, should be central to how this investment is rolled out, because they know best. They know best because they are living with it, and especially those families, as I say, who have now passed crisis point and who are sadly still there waiting on help and support. They need to be central to any conversations or travel of direction in terms of how the trusts are going to spend this money. Thank you.
Could I, Chair, just add that this investment is really welcomed, and it will kick-start what is very desperately needed for this system, but it is not going to provide for all of the families. It's not.
That needs communicated.
It's just not. We will require longer term, medium to long term residential placement beds for young people. We will require additional respite facilities across Northern Ireland, and the current investment will not look at that to the extent that we know it is required. But this is a really good kickstart to everything. The therapeutic interventions, the behavioural support, all of that is negligible across Northern Ireland currently. And for us to be able to build that is just such a welcome opportunity for us. And what we are trying to do about building respite and maximising our existing environment, if you like, that's what we're trying to do here. But there's no plan that's about building a unit that's going to be covered with this investment. It's just not.
Dan?
Yes, thank you, Chair, and thank you for coming. I just first of all want to reinforce what our liaison just said. I think that in a society it is cruel for families to have to come on TV and bear their family life. And they've been driven to that, let's face it, by the fact that they haven't got the help that they needed. And we can't hide from that fact. That is what happened. They didn't get help, and they were in crisis, and they sought a mechanism that would try to get them help. And what we found on Tuesday were families that were doubly disappointed, because when they had gone out and opened up their home, their family, and all within it, and all the raw emotion of that, they are here today, sitting behind you, and they still haven't help. And I'm kind of thinking, I mean, it doesn't speak well for any of us. It doesn't speak well. And I think we should all, I am appalled by it. Like everyone else, I watched the programme, I listened to the Minister's announcement, and I was devastated on Tuesday when I heard how little had actually been done for the families and what had been communicated to them. So I want to quickly ask a sort of a series of questions, really. I would really appreciate short answers because the chair is very strict about time. So I just want. So how many residential beds do we have in Northern Ireland, as opposed to respite residential beds?
I do a little bit of mathematics and take your next question because I have it by individual trust.
We have 5 in the Northern Trust.
So those respite beds, is that the same, residential beds, is that the same number that you had before COVID? Do we have more now or less? What was the impact of COVID on those beds?
The same.
The same number.
Those residential beds.
Anything
So how many
residential-
children now are occupying respite beds but in full-time care?
16 children currently occupy 26 short breaks beds out of a commissioned 45 short breaks beds, so over half the service.
And why have we not done anything to actually resolve that situation?
In terms of the proposals from trusts to recover short breaks beds with the additional investment, some of the children who are currently living in those units, the plans are to put them into full-time residential placements. That will allow us to recover part of our short break service. But as Maura said, this funding would never be able to, based on rough costings, you could have used the entire funding to buy back all 5 set residential placements for all 16 children. But with the gaps that you have within the community, particularly around family, therapeutic and behavioural, with 3 trusts not having a fostering short break service to the level that Northern and Southern do, the beds that you would recover would be lost again over time as the families who are in edge of care, even with short breaks provision, there will be a cohort of families that even with short breaks, their children will still end up in residential care. It's a smaller cohort, but it's a cohort of exceptional complexity in terms of need. So what will be achieved with the money is part of the short break service will be recovered through residential placements for some of the children that currently live in those beds. We have undertaken a residential capacity.
Can I just interrupt you there, sir?
Yeah, of
Because
course.
I do want to, I have a 3 or 4 questions. I do want to get them all in, and I want to be respectful to others in the committee. You have a situation where we desperately need respite beds. We desperately need respite beds for very complex children. There are many other children who will require respite beds who are not as complex. Some of them will go to the foster care issue, and some of that works very well. I've seen that in operation. But for the families that we were talking about and talking to on Tuesday, that's not an option, and that's not going to happen. How many additional respite beds will we see next year? Across all of the trusts, how many additional respite beds will 13 million invested get us next year? Sorry, can someone come back to us? It's really poor that we're not actually... These are simple questions. These are very, very basic questions.
The South Eastern Trust and Belfast Trust, it's 8 as well. So we have Lindsay House as a facility.
So those will be additional to anything that you had before?
They are not additional. That is helping us to recover what we already
had. So we're
had.
only recovering beds. We're not, and this money is not adding any additional beds.
Money is adding additional beds, but then we've opened additional nights in the Southern Trust and 2 other respite units.
Yes, I've spoken to the Southern Trust. You might not be surprised to know that, and I understand where those beds are. So I want to know, and I think the committee deserves to know, exactly how many additional beds that'll be created.
Sorry, Chair, can I just come back on that? Sorry, in the South Eastern Trust, whilst we will have Lindsay House open and that will help us recover what we previously had, we're also building and expanding what we already have in Greenhill, and that will be additionality. Currently, we have a small number of beds.
So how many will that be additional?
Well, we're hoping that will offer 6. It's 6 now, and we're hoping to move that to 34. 34, but that is dependent on not 34 beds, but 34 additional nights for children.
Yes,
and
so
families.
that equates to how many beds?
I will need to go back and check that in terms of...
It's very frustrating.
Apologies.
Can I just move on?
Okay,
because I do expect this information to come to the committee.
The number of recovered beds and the number of additional beds.
Yes.
You can break that down by beds and days.
Yes,
yeah.
I would have thought this is basic information. Maurice mentioned the number of unallocated cases of children in need, because I'm also interested in how we got to this appalling situation. And he did say that he had an answer, but he didn't share it with us. But I'll share it with you now, because I do have the answer in a written question. So for the Belfast Health and Social Care Trust, 34 children are waiting in disability services. For the South Eastern Trust, that jumps to 499. For the Southern Trust, that's 180. And for the Western Trust, that's 140. How on earth could the South Eastern Trust have got so far out of sync with 499 unallocated cases? And is this not symptomatic of how we've got to where we are?
Well, if I can answer that, the South Eastern Trust have experienced significant issues around social work recruitment, as have all trusts, but particularly in their Children's Disability Service. There has been, and that has been due to retirements, that has been down to workforce availability, that has been down to the availability of social workers across the region. We are looking at our list, and I can say with confidence that the children that are on that list require low-level family support, because I have looked at it and I have done an exercise that tells me some of those families require administrative support only by way of administrating direct payments. Some of those families are low-level, but we are in the process of looking at them all again and assuring ourselves we have a robust governance process in place to look at those cases on a weekly basis to make sure those needs haven't changed. What we are doing at the minute to manage that is looking at recruiting within a skills mix context. Like I said earlier, we're looking to recruit not social work staff, but other grades of staff, so that it can be a social work-led service, so that families get the support that they need. And that speaks to the Ray Jones report, because Ray Jones is saying very clearly that families need practical support at a time when it is critical to them. So that's not necessarily a social work support.
I don't really want to be rude, but I do want to move on just to my last question. But before I do, I want to say, that's fine. I'm glad that there's something being done about it. Yeah. I'm really glad. I'm appalled that it has got to that stage. The South Eastern Trust, 499 unallocated disability services, 118 family support services, and 71 gateway services. That compares to just the next one down on my list is the Southern Trust with 180, 27 and 49. And that, I mean, there's need everywhere. And that must mean that the South Eastern Trust have not, for quite some period of time, addressed that need in an appropriate manner. Can I just move on, and I'll just finish with this one, because I think, Chair, there's some really serious issues to answer here. When you talk about Lindsay House, and the fact that you want to get that reopened, would you like to explain that sort of just to me again as to how that's going to happen?
Okay, so Lindsay House sits in the South Eastern Trust area, but it offers short break services to families in the South Eastern Trust and the Belfast Trust area. Mm-hmm. So currently we have 2 young people in there on a long-term basis. We are hoping, well, one of them, their substantial placement is not in Lindsay House, so we are looking to move that child back to his substantive placement. The other young person will move to Redwood when that is open and available, and we're hoping that that is going to be, it's our intention to open that in September 2025. As I said earlier, we have recruited staff for Redwood, and we're in the process of bringing those staff in. Hopefully we'll be able to train them. We will, or it's our intention to train them to work with highly complex children. So when that young person does move to Redwood, we will be able to open Lindsay House to its full capacity again in September 20. That's our intention, again predicated on nothing else coming in.
And has the family been communicated that?
Yes.
Okay. Right, okay, to a degree I would have imagined, but anyway, right, that's fine. Look, I'll finish by saying that the other aspect of Tuesday that was very, very disturbing, I think, for everybody that was in the room, was this issue around how you communicate with parents and the culture of communicating with parents. And the idea that many of the parents felt almost threatened by some of the potential answers to their dilemma. And I suggest that there is some review of how that is done, how people are spoken to, and how families are dealt with. Because I was very disturbed by it. Thank you, Chair.
Okay, thank you very much, Dan. Linda?
Thank you, Chair, and thank you to all of you. I wasn't at the meeting on Tuesday, and I want to give my apologies, but I've met with the mummies before, and I'm going to concur with the comments of other members rather than taking up time, and it is, to be honest, distressing anyway to talk about it. A number of my questions have been covered, so I'm not going to go over those again, but just following on actually from Diane's point about getting an update on what the intention in terms of additional beds are, I think we need to, as a committee, get not what the intention is, but you said it yourself, Chair, about the updates. I want regular updates as to what real difference is being made to families, and that's right across the board at whatever point that intervention is happening. I'm concerned, I suppose, to be honest with you, in the differentiation in trusts, and to me, that is a departmental responsibility, because trusts can do what they do in their own trust area, but the department needs to look at every trust area and see what's happening. And the last point on communication, I think, is a really, really important one. And I'm not saying it's the intent of anybody in this room not to deliver for these children or families, but I do think there's a cultural thing. I think there's a cultural issue, and to me, culture comes from the top down and the bottom up. And we all have a responsibility to change the culture. I think there's been a poor culture towards these families and these children right across the board. I think it's a general thing. That's not an individual responsibility. I don't feel the need to respond to that. I think there is a cultural issue. On the policing board, we deal with cultural issues all the time, and anything we say here is to make things better. It is not a personal attack on anybody, so just to make that clear. But it is to make things better for these families and these children in particular. So just in terms of then specific questions, as I've said, we want to know the outcomes of the additional funding, and we need to get regular updates on that. We need to understand, and I am going to say, be as open and transparent as you possibly can. We are here to help. So is there a correlation, I just want to understand this, between the unallocated social workers and the lack of services? And I'm going to ask for honesty and transparency around this. Are social workers leaving because they cannot cope with having to deal with families that they cannot deliver for?
Certainly, based on the data we have in terms of vacancy rates and unallocated cases, we can see that there is a correlation between high vacancy rates. Diane, you had sought out, I suppose, laid out the unallocated cases in South Eastern Trust. Now, while they currently now have comparable vacancy rates to two of the other trusts, last year South Eastern Trust had vacancy rates of 55%. So they're coming from a position where that nearly over half of their children's disability team was depleted. You've mentioned also just about regional variance. There's two pieces. In terms of the additional funding, all the trusts were coming at different starting positions in terms of their respite and residential service, in terms of the availability. So we talked a couple of times about share the care. That's in Northern and Southern. The other trusts are in a different place with that, but they're working towards it. We have also, as part of the Children's Disability Work Stream, undertaken a regional consistency review, because there is a piece, and you should be aware in terms of our other sessions in adult LD, there is the lack of regional consistency across children's disability and adult learning disability services. So that review has been complete, and there's been a review as well of criteria that's used within those trusts. Until we achieve a level of regional consistency, and to be honest, until we actually commission the sufficient level of residential placements, we're always going to have a service that is going to be regionally inconsistent. The residential review that we've undertaken, it's not finalised yet, but in terms of indicative figures, what's needed for residential capacity is sizable over the next 5 to 10 years. Until we actually address that, you will have a short break service that's fragile, that's under threat. As Lynn and Moore have both reflected, if something goes wrong in someone's home, the whole service stops, it collapses. That's the point. We have a residential piece, a pressure across all 5 of our trusts, and it's impacting everything upstream, from short breaks to family support, but most importantly, the family home.
Just about one other quick question. There was a comment earlier around the respite provision not being a replacement for therapeutic support, which I agree. But can I just clarify, therapeutic support happens in the respite setting?
The care that's provided is in a therapeutic, within the context of a therapeutic framework, 100%, yeah.
I'm just asking that question based on the fact that I know that families are not getting the therapeutic support that they need at home.
Yeah.
But like all of us, these children are no different to the rest of us. And when you get a break and you get some kind of therapy for a couple of days, it can actually rejuvenate you for a number of weeks. It can offer relief to families for a period of time. And I'm not saying that's an answer. It's not. I understand that. So I just want to make it clear. And my final question then just is, in terms of that respite offering and the general question around multidisciplinary teams, can we get a sense, I'm not asking for this, but can we get a sense and an understanding of what that is going to look like in terms of the multidisciplinary teams? Because again, that takes pressure off any individual in those residential or respite settings. Is that something that is very much in place and embedded, or is that still something that we're trying to invest in?
CAMS ideas.
We'd ideally like to get to a position where we have a complete wraparound support for families that combines both the short break but also some further and additional support for the families themselves. That's where we'd like to be. And in terms of therapeutic support, we are developing our CAMS ID service. There's a very well developed service, you will probably know, in the Southern Trust area, which has proved to be a model for us to look at for the rest of Northern Ireland. And we have invested currently in additional member staff, for each of the trusts to begin that journey towards building that CAMS ID service that will be able to offer therapeutic support.
Just in addition to that as well, so the necessity for the multidisciplinary part of this, and in terms of behaviours of concern, it is moving away from instances where there's been diagnostic overshadowing, but it's simply been, well, that person has a learning disability and that's their behaviour. It's recognising that fully that particularly with a population that have learning disabilities, co-occurring autism and could be non-verbal, that actually a series of unmet needs can result in behaviours of concern. So yes, you talked about the importance of a therapeutic short break, a break for everybody, but equally an unmet physical health care need, as trivial as toothache or an ingrown toenail sounds, if that's not picked up with this population, it can present in the same way. If a child's not happy in school, if the environment's not right in school or at home, if they're having a mental health crisis, and that very much touches the point Maurice was saying around CAMS ID, then social work and social care and isolation, they will never be able to understand and respond appropriately. And that is the necessity for a multidisciplinary service to wrap around that child. Now, in terms of our rethought approach to residential care, it's very clear that yes, it will need to remain a social work-led service, but learning disability nursing and allied health professionals, specifically speech and language therapy and OTs, they need to be on site around that type of service going forward, because social work in isolation and social care, it's not enough.
Thank you, Chair. Just to say, these same families are the same families that are facing all of the challenges, and that's why I say there's a cultural issue that we need to address. They're the same families that can't access the multidisciplinary teams. They're the same families that can't access PEG surgeries. They're the same families that can't access occupational therapies and different types of surgeries. Our children's services are failing our children.
Aye.
Thank you, Chair. I find the documentary and the meeting on Tuesday when we met with the families again, unfortunately I wasn't able to stay for the whole time, but I found it very unsettling, really, really raw, real emotion, and to hear from the families that nothing had changed and in fact had got worse since the documentary, that is a matter of shame. We have children being looked after by their families, and their families are struggling and doing everything they can, calling out for help, and things had got worse since they had opened their doors, had their documentary teams in. That's shocking in itself. things they were describing as well are very dangerous situations. You know, we were talking about physical harm to parents. You know, people being actually physically harmed with the potential for worse, very serious injury that potentially could happen here. People are incredibly distressed, living on their nerves. I can't imagine the level of stress that they're constantly under. So it was really, really shocking to hear that nothing had changed and things had got worse. So just to let you know, when you've been speaking here today, they've been behind you listening, and there's been a lot of head shaking. There have been a lot of... So some of the things you're saying do not seem to be matching up with their experiences. Okay, in particular, I had one particular question. Maurice, just for yourself, you had mentioned other services are available for these families. Can you detail what services are available for these families and what they're being taken
I
up?
was referring to the waiting list, and I was referring to the waiting list and the unallocated.
Mm-hmm. What is available for these families?
Well, I mean, as Lynn has laid out, there will be other health services involved, there'll be other voluntary sector organisations involved, there'll be some assessment of their need done, and potentially referrals to other support services, as I say, voluntary community.
Okay. And also, I suppose, what came across a number of the proposals, there has been scale up for families who are on Educare of day breaks, which are short breaks delivered within the home, or a young person would be taken out. Look, we fully concede.
These being taken up?
So they would have high uptake across the trust ring. But look, we fully concede these are not overnight short breaks.
They are being offered and they are being taken up.
We're talking about, so I can only really talk about the population. We can't talk about the families behind us.
I'm not asking to you, I'm just in general.
Okay.
Sorry, I was talking about the unallocated cases. Sorry, I wasn't referring to the families in the room with us.
No, just in general. I'm talking
Okay,
about.
sorry, I just wanted to be clear about that.
How would you find uptakes for like day breaks and
Yes,
other types of short breaks?
Yeah, so the other types of support that's being offered in absence of overnight short breaks, and I have said previously that we are offering and have been offering, and they have been taken up, the overnight short breaks. I do appreciate some of those overnight short breaks. For some of them have been cancelled last minute, and I
The stress of that must be
yes,
phenomenal.
absolutely, and it is to say that sometimes that happens as a consequence of an unavailable workforce. And I will say that some of our staff in our residential facilities and in our short break facilities are experiencing some of the things that you've heard from the families, which is very distressing for the families and for our staff. That accounts for some of our staff vacancies when we can't recruit into those posts. So your question really was around our families taking up outreach. Yes, we have an outreach, certainly for my trust. I can't speak for other trusts, but in the South Eastern Trust we have an outreach service, and that has been delivering a small amount of outreach. We have been able to deliver outreach more extensive for those families who require a lot more. So that has been put in place sometimes twice, 3 times a week. And then it's also delivered at short notice. So if, for example, a short break is cancelled, then we put outreach support in place. So that is taking the young person out of the home for an extended period of time to deliver a short break, albeit it'll not be overnight. But there is that.
How long typically?
It could be the morning. The other thing that I want to couple of hours during the day. The other thing I want to reiterate is that there can be issues in relation to the young person's school placement, and this is why I feel this is a cross the whole systems, cross-departmental issue, because a number of the children that we're talking about are not in school because there are issues around their behaviour in school and they can't be managed and there's challenging behaviour. So then those children are being sent home to very broken families. Which you've heard. That's
broken
very
families because the system has made them broken. The system has done this to them.
Well, it's
Absolutely.
I think it's a whole systems approach, and I do think that there are things that everybody can do to try and manage this situation, and things that we will take forward to try and manage or try and do. But I do think this is not just a health issue. This has to be a whole systems-wide regulatory, education, a whole systems-wide approach to be able to manage it. But yes, there is outreach services being offered and they're being taken up.
And yeah, Danny, just in terms of your concluding point there, yes, the significant gaps that we have across services in Northern Ireland have eroded the resilience of families. They have changed their perspective of family life, and inevitably children are ending up in the care system that potentially, if we got support through the door much earlier, if we had a more resilient short break service, if we had shared care arrangements as families make their way through a continuum of need, we could have kept more families together. There still will be a cohort that will inevitably end up in a residential care service, and as they transition, they will most likely end up in a supported living or a high cost type of adult accommodation service as well.
But on top of that, there's also a cohort of people that are being forced into this.
Yeah,
that
certainly,
should not have been.
And so, like, some of our numbers have got worse. So at the time of decision of that funding, there were 70 families assessed of edge of care. Today it's 81. Okay, the waiting list for short breaks have not improved. Okay, so some of the numbers are either not improved or they've got worse.
I want to go back. Orlia made the point that those 81 families should be the centre of, the care should be built around them. And for those families who are on the edge of care, I think you're calling it's age of crisis. That's where those families are. The support should be ploughed into them to try and stem that flow into a need for residential. What are you doing in the future to ensure that respite services are protected so that number, that 81, doesn't increase? What are you doing to ensure that respite services will continue to deliver despite pressures from elsewhere?
So we've set out in terms of our children's disability framework, there's 4 key areas of work. I suppose to answer your question directly and quickly, the only way you're going to be able to protect that short break service properly is to have sufficient residential placements. Otherwise, your short break service is at risk of being repurposed. So you need that pressure coming from up downwards. You need to reduce that pressure. You need to ensure there's proper residential placements. So when a child enters care on a planned basis, not an emergency basis, we need to move away from that. That we have sufficient capacity in the system. Otherwise, your short break service will always be fragile. Now, equally, what's set out in terms of the children's disability framework around early intervention and community-based support. By getting around families much earlier, when their children are quite small, ideally much far ahead of adolescence, you can delay the inevitability that those families will need short breaks, and in some instances you can avoid the necessity for short breaks. So we do need to enhance that community piece as well. And then within short breaks as well, we concede the service. We need an increased level of service, but we need to diversify the service as well. And that's not unique to children's disability. I mean, certainly what we've set out is the importance of residential short breaks, but also fostering short breaks, day breaks, and the use of direct payments as well. In terms of our previous discussions, that's exactly the same approach we're taking in terms of adult learning disability. Yes, residential short breaks are important, but so are those other types in terms of shared care, managed budgets and direct payments. It's the menu of options for families to be able to bring in care that is personalised to them.
But to protect the short breaks, I mean, the residential piece is key, which is why we've prioritised getting that assessment of need done. And
I noticed in the report it said the assessment has been done.
Yeah.
But that we haven't seen that yet. So what
Really,
is that going to cost?
We've done apologies, across you. We've done our first cut of that, and we have and we've looked at each of the trusts, and we just need to go back to all the trusts again and say, this is what we understand the need to be based on the information we have across all the trusts. Now, are you content that that's accurate, and can that then be the basis in which we plan going forward? And obviously at a different reporting point with the committee, we'll be very happy to come back and talk about that. But
I look forward to seeing that, because that will give us a scale of the problem and a cost of the solution.
You understand my hesitation?
That's where we have to get to in order to.
And that's very much in terms of Maurice's points and Maura's points as well. This is why there is such necessity for sustained investment. Unless we get ahead of the residential demand. And look, the residential demand of today is inflated by the gaps in the service that we've had to navigate to get to this point.
Until
we address those gaps, that we may get to a point where that residential demand will drop. Once you get in the community piece and once you have a much more resilient short break service. But we have the demand of today, and that demand needs to be paid for.
Well, I would hope just in finishing that the families who are on the edge of care or edge of crisis, those 81 families, could get as much support as they can at the minute, and just they should be offered as much support as they possibly need in order to try and keep them psychologically supported as well, and members of the other extended members of the family, I know from the documentary, that are impacted by this, siblings as well, you know, that there should be support right around those families. So thank you.
Thanks very much, Dan. Alan?
Thanks, Chair. Look, there's the old saying is there's no future in the past. However, these issues that are before us today and have been with us now the past few months are nothing new. These issues have been highlighted by families for quite some years now. Some could even date back to a decade. So I suppose it begs the question, why over all these years, why then have trusts failed to protect the levels of demand and plan accordingly? And can also ask the question, it's a very direct question, did it take the Spotlight programme to release that money?
Yeah.
Did it take the Spotlight programme for these delivery plans that we have before us today?
Okay, I'll start with your second question then. It shouldn't take a Spotlight programme to enable a decision in terms of this area of work. What the programme achieved is it made it very clear to our Minister that the time to act was now. You will be aware, of course, as a much broader remit, as a committee, you will be aware of all of the pressures in health and the exceptional shortfall in terms of our budget and meeting those pressures. In terms of your initial question, yes, trusts have been able to see this come towards them, and to a degree, could they have made different decisions for individual families? Yes, but that would have had to be offset by making different decisions for others. But we live in a system where there are single-year budgets. So even taking the issue of transitions, we know there's about 300 to 400 children that will be moving into the adult LD service in the next couple of years. So we can see those children. We've known about them since health visiting picked them up, since they entered the social care service. But on single-year budgets, it's exceptionally difficult to plan ahead in terms of what money we will have next year and the year after that. So in terms of workforce delivery, that's a significant constraining factor for us.
As you said there, the key line, the time to act is now. But surely if the department and the trusts were aware of this trajectory, as I referred to some years ago, why was the time to act not then?
Well, I suppose the other key part was actually the strategic work that was already underway. So our children's disability framework had already been developed. It had set out the 4 priorities for health, which was this is the regionally agreed position of all trusts in terms of early intervention, community-based support, improvement of the short break service, rethink of residential care and transitions. So the strategic approach was agreed. Work had already been progressed in terms of the Children's Disability Work Stream as part of the Children's Services Strategic Reform Programme. That's the implementation of the Ray Jones work. So work was already underway. What this funding does, quite simply, is it rapidly accelerates a lot of the work that we have done to date. And, as I say, when we convened trusts back in October, the question, the challenge to them on that was, what can be done today? What can be done within days and weeks, not months and years? And we really challenge trusts to think creatively within our legislative and regulatory framework about how we can think about this problem differently. And certainly what's happening within Northern Trusts, what's happening within South Eastern, what's happening within Belfast in terms of a proposal I have around dual registration, this is about thinking about things very differently within the legislative and regulatory framework that we have. And where we are encountering barriers, we are pushing our way through those barriers in a risk-managed way.
Chair, I'm conscious of time, conscious there's others looking on.
Okay, thank
We
you.
could sit here all day.
Oh,
Thank you, Chair. Look, the majority of you are new to post, so these insults can't be directed at yourselves. You are new to the positions, but it is an absolute mess. The entire system has just broken down. I don't think it's on the edge of anything. I think it's broken. And it's families that are being left to pick up the pieces. And just echoing the remarks, having watched the Spotlight programme, met the families this week, one of the most disturbing matters was that if their cases weren't deemed desperate enough to have an intervention from that ERD 5 months ago, because they were telling us that there has been no input at all in terms of services. That can only mean that the services that have been provided in the last 5 months have been going to others that are deemed in even more severe cases, and the fact that that's the level of cases that we have out there is beyond disturbing. It's also matched by the fact that 13 million, I know it sounds like a lot of money on an individual line, but at the same time, the scenarios that we've seen, people being physically assaulted in their own home, no support being provided, the breakdowns that go with it, and 13 million is what we've come up with to resolve it. It feels like money could have been invested much sooner, and I want to build on Alan's question about how far upstream should we have been to see problems? Is there a system in place to monitor and say, actually, we maybe need to intervene now, because if we don't, this problem is going to grow? And notwithstanding some of the individual circumstances for it, and Linda put you a wee bit on the spot in this one, but to have nearly 500 cases unallocated, I'm actually one of the most scary facts. We have a workforce in a part of our health service that is 60% depleted, and I'm wondering, has there been an alarm bell sounded for that? At what point do you go 20% down staff time? That's a bit worrying. 30%, actually we need to do something about this. We get to 60%. What happens? Well, we can see what happens. We've all watched Spotlight. So where is the red flags? Is there a system that has been assessed now and went, do you know what, we need to make sure we don't get to that situation again? I could be smart and say maybe there's no alarm bells left because the minister's taken them all to power as irony klaxon, that that's maybe why there isn't any. But do we have systems in place now to check that 30%, 40% is too much and will cause problems?
Well, those vacancies are being very carefully monitored by ourselves and through the Chief Social Work Office in terms of an entire social work depletion across the piece, not just in children's disability services. For my trust, I can say that's where it's been most acutely felt, is it been in children's disability, with 55% vacancies last year, now reduced to 30%. So if you have that depleted service, what you can offer is a very reactive service, and a service that responds to those in greatest need and at crisis times. What you're not able to do is deliver the early intervention, which is really critical, and I think that's what you're referring to in terms of what can be done before a situation gets to a crisis point in time. So this money or this investment will help us to develop our early intervention models, and I do appreciate we've said this throughout this meeting.
And I get that, and I don't want to we've heard that a few times in the interest of time. Your department, your trust, at what point does the department step in if it gets worried about staffing levels? At what point does it, do you say 15% staff team missing, there's going to be a problem there? Do you go at 20%? Obviously somebody in the role before you has went 50%'s all right, we don't need to intervene here, because it's got the 55% of a staffing. And maybe just before that, like what would the lowest level of staffing levels been for yourself, say, in the northern?
So within our children with disability, we've kind of been around 25, 28%, something like that, which would be not unusual across children's.
But if it was 20-something% and then one trust that's sitting at 60%, I know if I was just simply looking at a bit of paper, I'd be going, there's maybe something here we need to intervene. So does the trust intervene? Does it intervene and help the trust to formulate some sort of services to be able to try and address that?
Yeah, there will be an escalation process if at different stages, depending on what that is, and that's relatively. We have a new system with that now, and that does include highlighting with the trust what the issue is, what's been done about it, what's the plan to make it better. In terms of your point about could we not see trouble coming, again, go back to Nigel's point, that's the work we did with the trusts and the department around our framework for children's disability. That's the bit that identified for us, this is what's wrong in the system and these are the priorities we need to fix. And I do want to emphasise that certainly we feel that across the 4 priorities within that framework, if we don't get them all right, we'll continue to have problems, because if we don't get early intervention right, we get pressure points with respite. If we don't get respite right, we get pressure points with children's disability.
And not to be disrespectful, we obviously failed spectacularly at that because we're in the situation that we're in. If you're saying that you've got the ability to look and see when there's problems and then intervene to respond to it, and we're seeing how families are being left in the community, then we're spectacularly failing that. I don't mean that that's not necessarily your individual faults there, but as a system that is supposed to have an ability to look and see where the problems are, and then we end up with the problems that we have, it's obviously wrong. Have you any...
This is an overall workforce, sorry.
Yes, but maybe, and that's what I'm going to say. What do you think? What is causing us to be in the state that we're in? Is there more people that need care? Is there less staff doing that? If there's less staff, why have we less staff? Where are the staff going that they're not going into these roles? Are there individual personnel issues within a trust? If one's sitting at 60% failure and the others are sitting at 28%, that says to you there must be something that's different there. That's just logic. But what do you think has caused the problems?
So in terms of look, in short, we'll come back to you in writing because I'm conscious we're already committed. We're going to get you, I suppose, some quantifiable data back in terms of the social work vacancies and allocated cases. But look, as part of that request, then we will also just engage with our colleagues in the Office for Social Work and try to understand what are the drivers around this. I mean, certainly you ask, is there more children? Yes. There has been a sizable increase in terms of the children's disability population known to social services. At the turning point of the pandemic, that population was 4,500. It's now 5,600. That's a huge jump.
Is there a piece of work being done to try and work out why that's the case? Because again, that's a nearly 20% uplift in figures. We need to have an understanding. Is somebody going, right, we need to go and find out why that's happening?
So part of it will be growth of population, but I think that we have to accept the reality that more children, because we're not picking them up earlier, are slipping into our social care, social work system. And comparatively with special educational need, since 2020 we can see very sharp increases to population size. So in terms of the SEM population, we went from about a 5% growth per year pre-pandemic. That's now very, at times spiked at 15 to 20% growth per academic year. So we're seeing similar in the health and social care piece. I think we have to accept that COVID's had an impact in terms of being able to identify children early within the home. But equally then, we're seeing an increased complexity of need through the system, a different profile of child that our services don't have the reach or the workforce to support well.
I'm going to invite Alan, but before he does, just on Colin's point, because we heard from a couple of parents on Tuesday that money didn't seem to be an issue. They were offered money, direct payments that they literally couldn't know. So a number of parents talked about having £10,000 in a bank account that they couldn't use. So to me it seems that the department has access to money. It maybe needs to look at how it's using that money. I mean, carers, for example, are not being paid a salary which fairly reflects the work they're doing. So I mean, Colin's asking a question. I'm not involved in the Department of Trust, but I off the top of my head know that if somebody's offered this amount of money for doing this job and this amount of money for doing a job that is much less stressful on them, what they're going to do. Social workers can earn equal amounts of money in the mainstream sectors. So, I'm not the minister, I'm the chair of the committee, I'm not in the trusts or a thing, but I would immediately be looking at how we pay our workforce to do these jobs. I mean, if employment's a problem and you have money that you're throwing at parents that they can't use for direct payments, then a simple alternative would be direct that money, pay people more appropriately and fill the vacancies for them to do the job. I'm just making that point, I'm not asking anybody to come back on it. Alan?
I watched the Spotlight programme as well. Very, very raw, very, very shocking to see parents been screamed at, been punched, been kicked by someone that they deeply love and care for. If you had open-ended interventions and money was no object and all the rest of it, what is the mitigating factor that you could offer those families to stop that happening? Is there any way of stopping that happening within the home setting? Or is it just something that is a fact of life that nobody can do anything about? It's really, really sad situation.
Can I answer that? I suppose what we try to put in place with families is we try to replicate behaviour support plans, so positive behaviour support plans. So techniques we are able to kind of teach parents, talk to parents about how to respond when a situation is escalating. That can be very difficult to implement for a parent who is under extreme stress all of the time. So whilst those behaviour support plans are in place and are implemented wherever the child is, whether it be in school or a short break unit or a residential unit or at home, we acknowledge that can be very difficult for parents to implement when they're under extreme stress and pressure.
I suppose just to that point as well, there's the recognition that behaviours most likely require a multidisciplinary approach in terms of trying to understand what's driving the behaviours. I listed a few things earlier, you go the school environment, the home environment. Undiagnosed physical health care needs are huge for the learning disability population. And they can be, unless we get paediatrics around them or when they're an adult and actually a doctor around them, you're not able to understand why they're presenting the way they are. And then that, before you can even move to the next step, which is actually working with them in terms of how they can communicate and interact with the world and understand their emotions, unless you have all of those tools together, then you're kind of setting the path of behavioural challenge. Certainly across health and social care, I don't think this is the reality that families should have to accept and the person supported should have to accept as well. This is unmet need that presents with behavioural challenge. So we need to address all of the unmet needs for each child. And part of those unmet needs may be where that child is living. And as I say, there is a small cohort within our children's disability population where there is an inevitability that they will be going to residential care at some point in their life. Historically, it would have been much more, but the present day, it is into a residential placement.
Very sad. Thank you.
Okay, thank you.
Claire, sorry, if I could, if you'd allow me, I'm so sorry I wasn't able to find this earlier, but just to answer your point, Diane, in terms of the additionality, we'll have an additional 4 beds per week in addition to the Lindsay House. If that opens, then the additionality on top of that will be 4 beds per week. Through Greenhill, the provision at Greenhill.
Annie, very, very quickly.
Very, very quickly. I just wanted to pick up on Whitehaven that had been mentioned more. I know I'd asked questions about this previously in October, November. We'd been told that it was going to open in a couple of weeks. Then, didn't. It's still closed now. You've just mentioned today that in the summer you hope it will begin to open and should be fully opened by the autumn, which is nearly a whole year. So I'm very, very concerned that this is just dragging on and on and on, and families in the East Antrim area are losing that respite availability. 5 beds gone completely for a whole year now when we expected it to reopen. Issue of concern, and I would ask that you please keep us up to date with, when that's open. I know a lot of families are very, very keen to.
And we completely accept that, Dana. We would like it open earlier. I suppose it is related to the complexity of a number of our young people and the care that they require, and some movement in respect of that has just not made it possible for us. But we are working very hard to get it moved forward as much as we can, and happy to keep you updated.
I know respite in there is precious to a lot of families. So.
Just and Whitehaven very much was an example of having to move somebody from A to B to C to free up A. There was a regulation challenge in terms of transitioning 2 young people into a supported living service. We have worked with Northern Trust in the RQIA and Positive Futures to resolve that regulatory challenge. And this potentially, and the delay is frustrating for Maura, her team, and the family supported, as well as the department. But this is actually potentially a new model for transition. So as children have entered the residential care historically, as they have turned 18, it all changes. They have to move, their staffing team and a new funding pot has to be found for them. With this approach that they're taking within Northern Trust, they're essentially getting ahead of the accommodation needs for these individuals before they turn 18. So when they become adults, there will not be any moving. The staffing team will still be with them and they will be within an adult programme of care.
Is that what we're waiting for? Are we waiting for these 2 to age out?
I really don't want to get into the particulars of individuals, but no, it's in relation to other young people in another
Sorry
unit.
if I've
Okay.
it's not an aging out piece. This is a proactive approach to transitions in terms of the accommodation needs. So
Those
Glad
that
to
are
hear that.
And I think that, as Nigel says, the very positive thing in it is whilst the Northern Trust has had all the frustration with it, I think there's potential benefit across all of Northern Ireland for this approach.
I'm just going to cut that conversation short. We've asked for regular updates and we've asked for a particular piece of information, so we look forward to seeing that. Maura, Lynn, Nigel, Morris, really appreciate you coming for us and taking those questions. Thank you very much. Okay, members, so just in terms of our committee, in the aftermath of that, we will write to the department just seeking regular briefings and progress reports on this particular issue, if everybody's content.
Could I ask that we seek the information on how we are doing? My understanding is that a lot of the beds that were used for respite have become residential beds over the course of COVID. So how are we getting back to the pre-COVID level of residential beds, and how much additionality the 13 million gives us?
I mean, and that's an important point, because we want to know that that 13 million is being used for additional services as opposed to being used for the services that we're currently there.
I think that my fear is that they're boosting services that are there,
Yeah.
without actually tackling the really, really
Oh,
hard
absolutely. It's
issues.
clear that's what's happening. It's clear. Linda?
Just in addition to that point, I this was a problem before COVID. This has been a problem as long as before I was even elected, when I was working in the constituency office. So it's been, and other people here today have alluded to the fact that this has been happening for years and years. So I agree with Colin, we're not blaming the people that are in front of us today, we're blaming systematic, complete ignoring of this problem. Can we get an understanding of what the Minister's plans are to ensure that there are adequate residential placements going forward? What is his plan for that adequate provision of residential placements? Because this is a false economy. We're ending up saving money by not putting in place the residential placements, but ending up with more children in residential, or at least needing, not always getting, residential placements because their families are not getting the respite they need. The point I made about those mummies getting, like, to talk about their therapeutic interventions is really, really important, but they are the therapy for their children every single day. If they're not getting a break, they're not therapeutic
We'll
for
ask that
themselves or
question.
anybody else.
Or Leah?
Yeah, just quickly. So the stuff around the South Eastern Trust, and Diana mentioned the stats in terms of that 499. You know, in terms of they're dealing with a highest volume of children who have this unmet need. But really, you know, we went around the houses for a few times. It's 2 beds that they're planning to reopen. It's not even new beds. It's 2 beds in Redwood in September 25, and I think that mentioned that, so they've 13 children that would be deemed on the edge of care, but they couldn't even give the guarantee. They were saying, you know, when these new beds or existing beds are reopened, that then again these plans might be disrupted if, you know, because out of those 13 children there's only those 2 beds. So and then the comment was also made, which like really shocked me, and where the girl from the Northern Maura had mentioned, she basically just says, look, there is no plans on building the unit, which is fair enough, and she says the funding will not deal, this funding that's been announced will not deal with the residential shortages. So this is the whole purpose of the conversation that we are having. So I just find that crazy. I don't know, I just think that, and this is what the family says the other day, the trusts are obviously working away on what their plans are and what they think is right. But this is not matching up to the need from the family. So I just think we need to highlight this with the Minister and work out what is actually, what, as Linda said, what is the plan out of that 13 million to deal with this crisis?
I think it was Diane made the point that the announcement for 13 million was in the aftermath of the programme to deal with that issue, and it's not clearly dealing with the issue. So, I mean, we will continually ask those questions and try and get some feedback. And I mean, at some point we're going to have the Minister in front of us again too.
We also ask if they can detail how they intend to stabilise and increase the staff. I think we need to keep the pressure on that.
No, absolutely. We need to pay them more. That's good. Danny?
Can I just ask, they mentioned those reviews, that they've done demand and capacity reviews, review of residential needs and projections, and a review of early intervention and community-based supports. They've all been done, they've said.
Mm-hmm.
Could we see the results of that? Is that possible to ask the department?
Certainly
for,
ask.
you know, because unless you actually know the scale of the problem, you know, how are you going to address it? But
Okay, moving on. Members,
Can I just, sorry,
Sorry,
can we ask for the information as well if it comes through? Can we make sure that it's clear? Because there was some of the information there. I have a GCSE in maths, but my God, some of that, like there was 16 people were taking 24 beds at one stage, and I know that they probably mean that there's a difference in staffing level, but I think we kind of need to be able to equate the information that they get that makes sense. But there is a concern that if they're saying that there's 81 that are on the edge of care, there's been a 900 increase in the population that they may need to serve over a period of 5 years. Is the 13 million enough? I think we need to know exactly what it is, but also there should be some sort of system within the department that they do not take respite beds to provide, they just have to come up with extra to deal with the residential that's there, but not to rob Peter, to not give anything back to Paul. So I think if there's a way of being able to try and manage that.
100%. And before moving on to item number 6, I didn't want to interrupt anybody during that session because I just didn't think it would be fair, but can't promise that's going to be the case moving forward. Okay, so next item is 6. It's RQIA officials, an oral briefing on the review of emergency general surgery in the South West Acute Hospital. So can I refer members to tab 6 of our pack? So that's a clerk's briefing on the review of pathways at the South West Acute Hospital, page 52, a copy of RQIA's review of pathways at the SWA in October 24, and that's at page 25, and then also there's an overview of the South West Acute Hospital review 10th of March 2025, and that's at page 116. So can I welcome Breach Donaghy, Chief Executive of RQIA, and Professor Stuart Elborn, Authority Member within the RQIA. So the witnesses have indicated that they would like to make a short, brief opening statement before moving straight to members' questions in order to make the best use of committee time. So fire away.
Okay, I'll just do a quick contextual introduction. So thank you for inviting us to provide some additional information on the independent review carried out by RQIA relating to the effectiveness of the clinical pathways in South West Acute Trust for general surgery following the temporary suspension. It's important to note that while RQIA were requested to undertake this review by the Department of Health, we did so independently and engaged experienced clinical staff to contribute to this review, which I think adds further independence and expertise to this process. While the focus today is on the review of South West Acute Trust and those pathways relating to general surgery, the recommendations that are in this particular review relate to South West Acute Trust or Western Trust with SWAH and that local population. We would point out to the Minister's response, recognising that all of the recommendations have been accepted by the Department and by the Trust, and that as a result the Department have committed to update the guidance and change and withdrawal of services document. So this will apply across the system and to all trusts where there is temporary or permanent withdrawal of services. This updated guidance will include the need for trusts to undertake clinical audits and or evaluations of how pathways are working and how those clinical outcomes are being achieved for patients. That includes the need to report findings of such audits and drive improvement, and includes the need to determine consequences for other co-located services, and the need for the trusts to be proactive in seeking out the experience of patients. So in summary, the recommendations are about the need to identify relevant data, act on evidence to support change and ensure good governance around this. And I'm going to hand over now to Breege, who will briefly summarise the 3 key recommendations of this particular review.
I'm happy to do that, Chair, but I'm happy to go equally to questions if that's your preference.
If you want to briefly just go through the key recommendations.
I'll just say briefly, I mean, there were 10 recommendations made. I would say at the outset, everyone we met with when we were undertaking this review, patients, their families, staff working in ambulance service, working in South West Hospital in Altnagelvin, clinicians, senior managers, everyone we met wanted the best possible outcomes for patients. There was nobody we met that didn't endorse that point. So I want to thank everybody for their candour and for contributing to it. And I know there were some questions about the recommendations in terms of the time scale of them. We haven't set out recommendations around 1 month or 2 months or 3 months. We've indicated different use of words around immediacy, some urgent, promptness, those sorts of things. We're trying to indicate the need for pace. And we do recognise that these things are not easy. Some of them are not easy to achieve. But they're focused around a couple of urgent actions around ambulance capacity and around ED weights, both in Enniskillen indeed and in Londonderry. And then also about undertaking, as Stuart said, audits and evidence to be able to demonstrate the effectiveness of the service, to give the assurance to the public, to patients and staff, to the board and so on, that the service and how it's operating and so on. But appreciating the time, we're very happy to take questions immediately.
Okay, and just I have a couple of other questions, but going to the question you mentioned there in relation to the kind of recommendations. So you talked about the urgent recommendations, fixing ambulances, double weights. I mean, has there been any progress in any of that to date?
Well, I know you have colleagues coming behind me, Chair, who'll be able to give you the updated information. I know really good efforts have been made, but I think you'll be able to demonstrate and colleagues will be able to say that there's still challenges in it. I know the Trust continue to publish their infographic on their websites, available to me and to all of you, and it demonstrates some of the challenges that are still being faced. But I know from the commitment made in the recommendations that there's a huge endeavour going on to try to address that matter, but I prefer, Chair, if the Trust would answer the progress on that.
We will ask them that, fair enough. So the Minister made a statement saying that he wouldn't be making any change without evidence, and I mean, we're all clear that we want outcomes for patients to be the way they should be, so that's good that he's not making any change without the evidence. In terms of the evidence and the data that you had available to you with regard to making your recommendations, I mean, can I ask if there was deficits? What type of data did you have? Was it good? Would it allow you to do the work that you were aiming to do?
Yes, I'm happy to answer that, Chair. We had lots of information available to us, which I believe we've made endeavour to demonstrate in the report, particularly experience of patients and their families is well evidenced in the report. Listening to those who have had first-hand experience of the changes was a big part of it. Also, the experience expressed by staff working in the services, both in ED and some of the others in an ambulance and so on. But there was a lot of other data available. We had the protocols available to us that had been developed to guide clinicians and the ambulance service during the changes. We had the information, all of the Trust board minutes and papers that were available to them. We had the infographic I've already referred to and some of the calculations. We had waiting times in EDs. Quite a lot of information. So much so that we certainly felt in a position to make 10 quite significant recommendations out of it. But there was an area that needs work. The Trust fully accepted that, and I understand are working hard to address it. And that was on the matter of clinical outcomes for patients on the pathways. Put simply, what people wanted to know was, if I need to have my appendix removed, and I live in Derrygonley or Rosslea or Enniskillen or Balik or anywhere else on that pathway, am I every bit as likely to have as good an outcome as someone accessing the emergency surgical service in Altnagelvin if they live in Londonderry or Strabane? And that's information. It is available, but it's tied up in the computer systems and the patient records. And the Trust were able to explain to us that the computer systems they currently have don't readily make that information available to them. It is there, it will be available, but it's going to have to be manually drawn out. But when we talk about clinical outcomes, I mean, these are not complicated outcomes. People want to know, will I stay roughly the same length of time in hospital? Am I any more likely to have an infection or some complication as a result of having my procedure if I've come through these pathways, transferring from Southwest rather than locally in Londonderry, for example? Am I any more likely to spend time in intensive care or in a high dependency unit? Am I any more likely to be readmitted after I've been discharged with some post-discharge complication? People wanted to know, is my outcome, my time in hospital, anything I will experience, is that likely for someone of the same profile as me, age, other health conditions and so on? And if so, if that information was available, what we heard was that would provide a lot of assurance to people that despite the difficult journeys, despite the ambulance transfers and many issues we heard about, distressing and anxious aspects to it, of course there were, but overwhelmingly what people wanted to know, will my outcome be the same?
Just so that I'm clear, you're saying you weren't provided that information?
That's correct, Chair. We wouldn't have that level of information. We spoke with the Trust about it. They do recognise that information is possible to get, but it does require significant manual effort.
And how much of a hindrance was that lack of information to you in doing your work, producing your report and making recommendations?
Of course, I think it would be preferable if you had it available immediately. But I think the important thing is we still made, with all of the other information available to us, and let's not underestimate, statistical data such as clinical outcomes I've modestly described there would be vitally important for reassurance. But information from patients, from frontline staff, information available to the Trust Board, all of that was sufficient for us to make 10 very significant recommendations. And in fact, I think as a result of that, it has shaped, I'd like to think at least, it has shaped the kind of clinical audit programme that the Trust will carry out, because it informs then of the kinds of things, types of information that the patients and public and staff want to see and hear about. And I know we didn't put timelines around them, but we said several of these areas, some, and if we get an opportunity, I would like to describe that issue about immediate patient safety issues, because I know that is something people have asked us about. But these issues, we've said, must be undertaken at pace. And we will be meeting with the Western Trust Board in the early April, and I'm expecting, assured, that we will be hearing, not only discussing about the report and its findings, but progress with some of that work. There's a full commitment to undertaking it. I have no doubt that the work is underway, and as soon as it's available, I think that will add a huge element to the assurance, that layers of assurance that are necessary to indicate to people these outcomes are acceptable and indeed improved perhaps on previous. So that all has to be made available to the board and to the public.
Oh.
Thank you, Chair. Thank you for your presentation. I was wondering if I could ask, obviously one of the most important things that will guide an investigation like you have done is the terms of reference. That's pretty important. It tells you exactly what it is that you need to do. But there were quite significant differences between the terms of reference as were set down originally as to the ones that were in the final document. There were a number of words that were missing that would somewhat direct you in a different way. Were they changes that you made, or were they changes that the department asked you to make?
There were no changes, and I would wish to apologise to the committee and to the public and to anyone else that was caused confusion. It entirely lies with me, my fault. There was a transcription error. I would challenge, if you don't mind, I don't believe they were materially different. There was a couple of words about population health missed and something. That was entirely a transcription error from the original terms of reference to the final document. The terms of reference never changed. We never changed in our endeavours when we were out there. We always intended to look at population health issues and patient safety issues. I do apologise that caused confusion.
Well, I thank you for the apology. I think it does. It's created a lot of mistrust in a situation where there's already mistrust, and I think that even the fact that the words were like system learning, that's a pretty big piece of information whenever it comes to a review of what's happening in a situation like this, and for it to be removed in the final version kind of give the suggestion that there were no system learnings, or that wasn't a focus, and the patient population outcomes obviously if you're talking about moving emergency surgery, there could be nothing greater to the patient or the personal outcomes than that. So, but anyway, that maybe just...
May I just quickly say, though, whilst I do accept entirely the point you're making, it caused confusion, I do apologise for that. But actually the outcome of this has actually been system learning.
Yes.
I mean, I know you may well have looked at the Department of Health's response, and I really do want to emphasise that the learning out of the Western and Southwest Acute has led the department to determine that all service change in future, temporary or permanent, will be subject to independent evaluation at 6 months and will have already led up to it a clinical audit programme. This is really, really important because we know as a community we are facing into service transformation. Hospitals are going to be different. Yeah. This is now a commitment, learning from SWA, that in future this will be the norm. So there couldn't be anything further. I mean, this is the most obvious example of the system learning, despite the terms of reference causing that confusion.
And just additionally, the systems learning depends on connected data and information so that we can really develop that into evidence, and I think Encompass will help with that. But there's other parts of the health and social care system where we need to be also accessing data. So, for example, NIAS needs to talk to the trusts, etc., in terms of real data, and so there's, I think, still a lot to do in terms of that digital transformation.
There were 80 patients that were part of your patient experience piece that you did. That is that a good number of people, or is that a regular number of people, or is that a low number of people in terms of these types of...
I would say this review is not typical, but in terms of engaging with a number of people, that would be exceptional. That would be a high number of people that, and you will have noticed too, significant number of frontline staff we engaged with. But, and I'm not saying that we've received everybody's views and so on, but that would be quite a significant number of people, yes.
If there was an exceptional number of people, in your own words,
yes,
and you made 10 recommendations, why are none of them relating to Section 7, 8 and 9, which is to do with patients, families, staff and stakeholders? If they all engaged in the process and told you their views, but whenever it came to your outcomes, you haven't provided any outcomes that addresses their issues, and it was an exceptional number of people that were engaged in that process, they might feel a little bit left out as a result of that.
I hope not, because I actually wrote a paragraph leading into that section to say that they underpin all of the recommendations. We don't attribute recommendations to the public. The public are not accountable for making the recommendations. We listened to their experience, and it has led to all of the recommendations. I actually wrote a little paragraph leading into that section, or at the end of it, to say, you will note that none of the recommendations are directly related to patient experience, because they're not accountable for it, and they shouldn't be, that's a direct consequence from somebody telling us something. We triangulate, or whatever word you want to use, information we receive from patients and their families, with clinical information from frontline staff, and the recommendations are ours. We're accountable, we're responsible, and the public and patients have informed that.
Not so sure people engage in a process to be triangulated, but I think they want to be able to see their recommendations in the report, but there was some of it there. My final question is, if people, as a result of this process, are having to move from the SWA up to Altnagelvin, that's a considerable distance. It's going to be a considerable impact on those individuals that have to be moved at some of the most difficult times in their lives. I would have thought that it's a small point, but that there might be some impact on the medication that they have to take, or the medication that is administered to them, or the handling of their medication. Would that have been something that was
mentioned
or
yes.
discussed?
Oh yes, many patients mentioned medication to us. But the important thing about, I'm reflecting from the review, the important thing about patient experience is what we wanted to hear from patients and reflected on, and their families, was how they were treated, how they felt, what they observed, all of that. Though we identified in the report things that lots of people told us, particularly the second wait in ED, people found really distressing, and all of that. The journey they found distressing. Medication management, prescribing and administration of medication is unique to each individual. I can understand sometimes patients may have their concerns about it, but it is a part of clinical practice. It's not a patient experience issue, it's a clinical practice issue. And we would expect that to be examined thoroughly in the clinical audit programme, because the management of medication, clinical decisions, the journey from Enniskillen to Londonderry, all of those things may have an impact on the clinical outcome for a patient. But I know we will understand that medication prescribed to someone will take account of their condition, their comorbidities, their age, a whole range of issues. That is not an experience issue, it's a clinical practice issue, and we would expect that covered in the clinical audit.
The report doesn't mention medication anywhere.
No, it doesn't mention it in the patient aspect, because that was not these are personal issues to patients about their medication. We've mentioned throughout the report about the need for clinical audit. And clinical audit would also cover medical decision making. It would cover medication management. I'm sorry that the report doesn't mention every aspect of clinical audit, but I would expect medication to be a key part of it. I'm sure as a medic, Stuart, you would expect the same.
And I think the management of medication is that there's adequate transfer of information from SWA to ambulance to admission into Altnagelvin, and that should be a routine area of audit undertaken within the trusts.
I'll leave it at that. I just worry when we say should be. You've completed a report. The idea of a report is to find out what happens and make recommendations. But if we have to leave it at the end of it of that should be kind of in there somewhere, it's that type of doubt that concerns people. But thank you for your presentation. Thank you, Chair.
Thank you. Linda?
Thank you for your presentation so far and the answers to the questions. Chair, you've covered most of it, but I just want to go back to the data issue. So I suppose my concern is if you don't have the data, how did you decide that people's outcomes will be worse? And I know you're saying they do have the data, but they hadn't pulled it out. So I have a wee bit of concern, and nobody will speak more clearly, and nobody is more in the record as saying best outcomes for patients. If my person I love is sick, I want to get them to get the best, not the closest. So I'll absolutely, but it is about access, and particularly for those people in Fermanagh. So it is about outcomes, and I just want to get a sense of that. And do you expect that work will have been done by the time you meet them in April, or do you not know the answer to that? Obviously, they're coming in behind you, we can ask them that. But
might be better, Linda, to double check that with the colleagues, but we indicated that there was a need to work at pace. And although the report was published there by the department in late January, it was submitted to the trust in October. And indeed, we give feedback to the trust colleagues and to others at the end of last summer. So I'm expecting when we meet with the trust that there will be really good progress in that. And I know there was a full commitment by the medical director and the senior team to undertake clinical audit. So, and although that particular element of it was not available, the trust did provide, for example, and I know you'll have the medical director here today, but were able to provide mortality information that they had studied and had not seen any particular outliers. We had recommended, well, mortality, if people pass away, that's obviously a very important outcome, but it's not the only one. Patient experience was a massive part of this piece of work, and staff experience. Those two things alone, supplemented by the information the trust was able to provide openly, and they didn't have any qualms about that, we made 2 recommendations for urgency. And, we don't use that term lightly. We said urgently there needs to be additional ambulance capacity put in place. And urgently there needs to be an redress of this idea that people wait twice in an ED. And we've said already people are making efforts on it. But I do think it's important to make a point here. The ambulance capacity in particular, we hear, sadly we all hear of the pressures on ambulance services, and indeed earlier this week I saw the Northern Ireland Audit Office publishing the report on it. But I do think it's important to say in this case, this issue about ambulance capacity serving this particular geography, this isn't a pressure. It presents as a pressure, but it is a known, quantifiable, understood change in the service. People will now be seen in Altnagelvin. That generates a quantifiable, predictable increase in demand. This isn't about the winter. This isn't seasonal. This isn't, something that's unpredictable. And that's why we point out that, in fact, in the West, in this area, there is an opportunity to demonstrate that service change is followed with a change in the ability to access the new service model. You said yourself, I think, Chair, people have to be able to access the model or the service. This is emergency general surgery. We know the Minister has spoken before about people's willingness to travel for specialisms, and I think that's probably understood by some and not agreed to by everyone. But this is a case, this is emergency surgery. So people will need to be facilitated and assisted to access it. The ambulance service have indicated that at the minute, whilst they have put in additional capacity, it's very much on goodwill, crews working overtime, those sorts of things. We made it urgent, but we didn't say 2 months, 3 months, 4 months, because you don't create ambulance crews and vehicles overnight or in a week or two. But there is an urgency to put additional capacity in there. And that was expressed by the ambulance service. And they explained in their report about the amount of money they're spending. They make public their response times and so on. None of these things are in isolation of each other. The changes in the South West Acute and the transfer up to Londonderry for the service isn't in isolation of the winter and pressures. And all these things do get mixed together. But this is specific. This is predictable. This is a service change. And that's why we are, to be honest with you, absolutely delighted that the department have used the review from the South West Acute and the West to say that every service change in future must be accompanied by a 6-month post independent evaluation, not waiting on the outcomes at that time. The clinical outcomes, as we've described and discussed, would be available because that's already required, and is the engagement with patients. So this is an opportunity here for this piece of work, although it was born out of crises. It's 2 years on now, and whilst I know it's still temporary and so on, this is people are relying on this service. So there needs to be a demonstration that the service model can change to adopt to a new delivery model. Not every hospital will have the same service, we're told. Therefore, this is the opportunity to demonstrate that. And that is why people should not wait twice in ED. It was dreadful patient experience. You saw that in spades, and it's definitely not good for ED. ED is already operating well outside their scope and capacity. The last thing they need are people entering into it who've already been assessed for admission and require admission. That doesn't mean it's easy for the trust to create that additional bed capacity, but this is a changed service model. That is the challenge. The model's going to change, therefore we have to demonstrate that the changes effect that, allow people to access it. So we were, despite not having those clinical outcomes that need to come from audit, those two pieces in themselves are really significant principles that must be applied to service reconfiguration. And that's why we did not want to wait for the clinical audit outcome. We've recommended clinical audit be carried out. It's been accepted. We've even guided as to areas that might be useful to look at, the effectiveness of the ambulatory care unit, all of these other things. But these are important. And I know there's time is short. There was an issue we raised earlier about not identifying immediate patient safety issues. And many people have spoken to me about that since and said, I can't understand how you didn't identify immediate patient safeties. And I'll say as quickly as I can, Chair, what we mean by immediate patient safety. When our QIA staff or anyone that engages with us go out to do a review or an inspection or an investigation in a hospital or care home or anywhere else, if the team identify on that day an issue that's putting patients in immediate harm's way, they will not leave the site that day till they speak to the person in charge and point it out to them. And they expect a response that day, the next day, but it's immediate. That's what we mean by immediate. It must be acted on immediately, no delay. It must be done hastily. I'll give you some modest examples. You go out to a ward and you find vulnerable adults at risk of choking with a lack of supervision and support at meal times. That must be acted on immediately. We won't wait. This cannot wait for a report to be written and send it to you 28 days later. No, That must be acted on today, and we want assurance today. Environmental issues, fire hazards, in medicine trolleys not properly managed, or mismanagement of medicine, immediately. But the other bit of those immediate actions must be that it is reasonable for the trust to be able to act. So you and I know that people come to harm when they're queued up in ambulances at our hospitals. Yeah. You and I know that people are coming to harm in our crowded EDs despite the best efforts of staff. They're coming to harm. It would be unreasonable for RQI to go in and say, resolve the ambulance queue immediately. It is not within the ability for them to do that day. But they must deal with issues within that. So, for example, there may be actions required in ED to make sure that if you have a spill-out area, it's definitely not desirable, and are people coming to harm? Yes. But are we clear who's in charge? Are there medicine card decks available? Is there good infection prevention control going on? Those are immediate issues. So when we said we found no immediate patient safety, there was nothing the team saw on the day in their observation or in the information they had that they were able to say, or the environment, that they were able to say, that's to be resolved today. But 2 issues were urgent and all other issues were prompt. We're demonstrating there these need to be completed at pace. We can't say 3 months, 4 months, but they must be completed at pace. They are all, really important to address. But I hope that might clarify a little bit about what we meant by immediate. Because I know 1 or 2 people have said to me, from colleagues amongst yourselves and others, I don't understand how you didn't find immediate issues. But they have got to be addressable by the trust and must be acted on that day, the next day. There's no debate about that.
Yeah, that was very clear for me.
Can I just say thank you to Breach for being so clear, because now we know exactly how reconfiguration should not happen and why rural people are so terrified of it. Not because you may not have better outcomes, but actually the things that are supposed to be put in place to make sure that you have better outcomes are not being put in place for planned service. That's for planned service change that we're talking about now, not collapse service.
Diane?
Yeah, thank you, Breach. I think that was very, very helpful. You said that one of the good things to come from the RQIA report was that every service change must be accompanied with a 6-month post-clinical evaluation. Would it not be helpful to do some of this beforehand to actually understand how things are going to work?
I think that's absolutely critically important, that we baseline before we introduce change, and then we measure what the change affects in terms of outcomes and processes. So absolutely, and I think we need to get to a health and social care system where data is joined up, because you can then do this very efficiently. We don't have the staff and the capacity to do data management bespoke to every question. We need to find a way to do this in a systematic way so that we can assess change in an appropriate and understandable way for staff and for patients and for the population.
I think patients and our community in general feel that health service is so dire that actually there's nothing we can do but change. But I think they want to know that everything is in place to make that change, as you say, workable and deliver better outcomes. And it seems to me that doing some of these evaluation post-change is a bit sort of after the horse is bolted sort of stuff. So that's definitely a question I will be asking the departmental officials who can have it already. I just think that's.
And in this situation, the change was made, and then we were asked to do the review. But going forward, we would really recommend that we're part of a journey on this, so that we can get the right evidence.
So that issues
and make the right
like
decisions.
the proposal around the Northern Trust, that those evaluations are done before the change is made, not after the change is made. And people will know exactly what to expect or not to expect, or whether that is possible in that context. That's very, very helpful. That is very helpful indeed. Can I just ask one last question about the issues? I had noted Colin's questions about the terms of reference, but can I ask a question about the private ambulances? The Northern Ireland Audit Office report this week actually indicated to us that private ambulances are not regulated in Northern Ireland. Is there a concern?
Yes. Yes. We would recommend that they are regulated, and I think we need to now engage in a conversation around this. It's noted in the report, our report, but also very clearly in the NIS audit, and I think it is important that they're regulated. They are managed by the trust in a contract, but there's no regulatory requirements. That this might need a change in legislation, but we would be strongly recommending that these are that a regulatory process is undertaken, that they're registered, and that they have some quality assurance standards to live up to.
And that this should be part of planned change.
Yes.
Yes. Under the current legislation, as Stuart says, RQIA, the only ability we would have with the private ambulances would be to review, inspect or investigate the contractual. We could look at private ambulances through the contract with the trusts, but we could not look at their role more broadly. And I mean, private ambulances be providing services to hospitality, festivals, a whole range of things. Sporting events, no doubt. We could look at private ambulance, and indeed may do, if we're able to have the capacity to do it, look at how it's contributing, because there's a role for private ambulance, it seems, and we can see that it's increasing, but at the moment they are not subject to any regulation.
The private or independent sector is growing in Northern Ireland, and I think we're exercised by that, and I think right across that independent sector we need to ensure we've got the right proportionate and appropriate regulation to ensure safety.
And finally from me, did you look at ambulance wait times and the potential, I mean it's a long way from Rosslea to Altnagelvin. It's just a long way. I know Fermanagh very well, family from Fermanagh. It is a long way. It's a long way if you're waiting on an ambulance even to get to Enniskillen from Rosslea, but then to know that you have to go the other bit of the journey. Was there any work done into that and the potential that might cause for harm to patients, and how the department looked at that kind of rural needs assessment in relation to that?
We did look at the ambulance response times because they're in the public domain. Ambulance service also provided it with a lot of information. The review team, I didn't personally, but the review team visited the ambulance headquarters and all of that. It was not possible to isolate the impact of the service change in the southwest as a discrete piece of the ambulance response times. As I said earlier, it adds in an additional pressure, and we can see overall that the service pressure for ambulance services is not abating, but it wasn't possible to extract out the direct implication of this, and so we did not go into that sort of level of detail. But I suspect the ambulance service would be well able to give an indication of what impact they're seeing on the ground.
Thank you. I think there's a bit of clarity for that as we progress to talk about potential change, and I do hope that the department take that up as principles for change. Thank you.
I should declare an interest. Somebody who fell off in the middle of a bike race and broke 3 ribs and a collarbone. I had made good use out of a private ambulance service that day. Just before I go to the next speaker, I just want to ask, just because there's been a bit of conversation about ambulance, has the RQAA considered any contingency measures yourselves should the ambulance service at Altnagelvin become overwhelmed?
Contingency in what respect, Chair? I mean, RQA's role is, in terms of the HSC system, is, I'd use this word too much, I know, but relatively modest. I mean, much of our endeavour is around registered services. The trusts, including the Ambulance Trust, are subject to a statutory duty of quality. They are accountable for the quality and the commissioning and all of those services through to the Department of Health. Now, RQI's role is to go in and shine a light on issues to help inform the department about that. So I'm maybe not understanding properly, and I'd be very happy to take
Okay.
more
Well, in terms
clarity
of
on it.
shining the light of a problem that may well encounter as a result of this change. One of them, as a layperson, I can envisage an already under pressure ambulance service becoming increasingly under pressure, and I'm just wondering, in terms of your role and your recommendations, have you considered what should happen in those circumstances?
Certainly, I suppose maybe you're entering into, if the recommendations are not acted upon, we would have a concern about the implications of that for patient outcomes.
Okay.
And it might well be that despite the responsibility for the actions being taken lies between the Trust and the Department, RQI have an independent role, and should we be concerned that there was a situation arising that these had not addressed or hadn't been addressed, we could use our role to investigate, inspect and shine a light on some of these issues.
Okay, fair enough. Thank you. Danny?
Thank you, Chair. That's been really useful so far today. It was great to read the report, the detail, the considerations, everything that's been put into this. We are in a time of change. Our health service is going to change. We know that we're going to have to manage change over the next couple of years, and having things like that independent evaluation 6 months after and beforehand, as you say, baselining it. These are things, we have a structure of change now that we're going to be looking at. I'm very familiar with RQA, let's say, just as a nurse previously, as my background, obviously I know the levels of risk that you look into and the things that you do to keep people safe, keep patients safe, and that's absolutely the right thing to do. Very surprised to hear private ambulances aren't regulated. I wasn't aware of that, which obviously is something I think we should be looking at, because they are transferring sick patients on a road network from hospital to hospital. Yes. With that, quick question just about the extent of the assessment at SWA, and how somebody is assessed at SWA before they're transported further on up the road to Altnagelvin, and how that information is passed between SWA and Altnagelvin.
I think you'd be taking us out of our comfort zone a wee bit in there, because although I do have a knowledge from colleagues who attended and visited the Southwest, and my understanding is when patients are assessed in the Southwest and accepted for admission to Altnagelvin, from the point of transfer on, they are under the care of the surgical team at Altnagelvin. But to be perfectly honest, I think, Stuart, unless you feel differently, I think the Trust would be much better to give you the detail on the detail of that. I wasn't personally out looking at that as clinical staff who went out and assessed that. They were satisfied, I have to say, with the assessment methodology, and you'll see in the report that there was compliments placed on the work done in the ambulatory care unit in Enniskillen, and so much so that the review team recommended that it should be further assessed and look at the success of it retaining people in the Southwest area and so on. But the detail of how people are assessed and triaged and decisions made, I would, if you'd be kind enough, ask the Trust that question.
But we are moving from sort of paper-based handovers to digital handover with Encompass, and Encompass will follow the patient, or the patient will follow Encompass, whichever, but there'll be a digital record that will be accessible as soon as the patient leaves SWA to go to Altnagelvin. They'll be able to see all of that data.
It does seem to be something that's highlighted in the report, is the communication.
Very
certainly between the emergency departments and the ward and the hospitals, but certainly Encompass should improve that. But that's something we've heard time and time again here in this committee. Encompass should improve that.
Encompass isn't the whole solution, but it's a big part of it. It will track with the patient, but we still need to join up other data inputs like NIAS data. How does that align? Does that help us understand perhaps why there's delay? So there's a lot of work to be done, but I think we're moving into an era where we have a really strong base to do that, because we'll have the patient information across the whole system.
I totally agree. The more information we have, the more we understand what's happening within the system. One quick question as well. On recommendation number 6, it mentions palliative patients and end-of-life patients. At what point would you be transferring end-of-life patients between hospitals?
I suppose, again, you'll have to ask colleagues, but end of life doesn't mean end of care. So there may be situations where someone's facing into an end-of-life situation and still requires some type of intervention for comfort, for pain relief, for, a whole range of things. But I know from speaking with Trust staff, and I think we've reflected in it, that the Trust had been looking at alternatives to transfer of some patients who, might be coming from a care home situation or, after a fall or palliative care, that there may be circumstances where patients don't need to transfer, or those that do have an intervention and return as early as possible to the Southwest Acute. But again, I'm not clinically qualified, so I would prefer perhaps if the medical director might answer those types of questions.
I think given the sensitivity of that situation, absolutely. No, that's great. I'm happy with that. Thank you very much.
Thank you. Alan?
Thanks, Chair. Breeze and Stuart, I don't proclaim to be any expert on the issues around SWA. I am aware, though, of that lobby group, Save Our Acute Services, and it appears, as an outsider, that they have fought admirably for their services. But like the lobby group in Causeway, who similarly are trying to fight for the retention of emergency general surgery. I know they have. I got sight this morning of their response to your RQA report, and I would be doing them a disservice if I say that they savaged your report. I think that would be wrong. I know they've used some of the language such as flawed. Have you sat down? Do you intend to sit down in order to clarify some of the concerns that they have? They have a conclusion here, and I don't want to publicly embarrass yourselves, but it is quite savage, some of the comments that they have said, and I think it might be beneficial in order to bring clarity and to smooth out any issues that group has with yourselves.
Absolutely. I've met the SOAS group many, many times, and met them a couple of weeks ago after the report was published. They came up kindly to the RQIA headquarters, as they have several times, and we spent a couple of hours together, myself and Dr. Miriam McCarthy. We met Jimmy and Helen, and we met Father Darcy, and they were always, as always, really respectful, provide lots of information and their evidence to us. They've done a huge amount of work for it. We have a huge respect for the SOAS group, for the other lobby groups, because people are putting a huge amount of time into all of that. I know they don't agree with our report. I just received their formal response to our report yesterday. So it'd be, and I will absolutely meet them. And I email Helen, Jimmy, 2 or 3 times every week. So we're not, covert in any way, and we accept that others don't necessarily agree with our findings. But what I've tried to say to the SOAS group is, I can understand your concerns. Absolutely. All of the things you've said, we understand what you're saying. But what we want to make sure is that there's evidence there made available to you to let you make a decision about this. Making claims about wanting to hold a local service, there's no difficulty with that. People hold those views. But what's important now is to put the evidence in place so people can be assured, and not just the campaign group, but as I always say, the quietly concerned. Those that don't campaign, those that sit at home, those that just worry about it. So the important thing is put the evidence into the public domain through boards, through infographics or whatever, but make it available in understandable language. Is my outcome going to be every bit as good as somebody from Strabane or Londonderry, despite those difficult journeys? And what are you doing about making those difficult journeys in ambulances from Rosslea or wherever better? What are you doing to make them more sustainable and more comfortable? So what we say back to SOAS is, let's look at the evidence. We know your point of view, we respect your point of view, but let's look at the evidence and let's see what it says.
I'm glad, Breezy, that you did bring some clarity to the terms of reference issue, because it was one of my questions today, and I'm glad that you clarified that to Colin. So thank you, and I do welcome that you do intend to meet with SOAS.
No difficulty.
Okay, thank you. Breed, Stuart, thank you very much for taking our questions. Thank you very much.
Chair,
It's been very helpful. Okay, members happy to content to move on to the next item. Okay, so
Chair, just if we could write, because I'm just a little bit disturbed at some of what I heard there, which is that if something is an immediate concern but can't be fixed, it doesn't get raised. that's scary from our regulator. That actually shakes me pretty much to my core. That if you have a regulator that goes in to somewhere and sees that something needs to be fixed immediately, but the underlying principle is that if you can't get it fixed that day, you don't record it as immediate.
I'm not quite sure that's how she explained it, Colin. I don't know if ever. I mean, or that's not what I took out
That's
of
what
it.
I heard her saying, that if it is immediate and it can't be sorted that day, we don't follow it up as immediate. Now it may get downgraded to urgent or whatever, but
I mean, I'm happy to write for clarification on the issue.
I think we should get clarity in that, because if that's what was said, that really is frightening.
Linda?
It's okay. I'm fine to write for clarification, but actually what she said is where it is an immediate concern in terms of you'd want it fixed immediately, but the reality is it can't be fixed immediately. You don't have more ambulance services, so you can't say the ambulance issue needs to be resolved today. It is urgent and a priority, but I think to get it right would do no harm.
Yeah, just to clarify, because if that was, it would be something that we'd want to be on top of.
I mean, that's the way I took it. That there are things that need to be fixed, but it's impossible to fix through.
Yeah, but you don't then not downgrade it. Okay. That makes it still urgent.
Fair enough.
Yeah.
Right.
Okay.
We will write for clarification. Moving on, item number 7, Departmental and Western Health and Social Care Trust joint briefing on the review of emergency general surgery at the South West Acute Hospital. So can I refer members to tab 7 in our packs? This includes a written ministerial statement on the review of the pathways associated with the temporary suspension of emergency general surgery at SWA, and that's at page 123. That's beautifully done. Can I welcome Dr. Thomas Adele, Department of Health, Dr. Brenton Lavery, Western Health and Social Care Trust, and Mark Gillespie, Western Health and Social Care Trust. I do note, I should say at the beginning, none of you are the Chief Executive or Chair of the Western Health and Social Care Trust. I think it's probably disappointing from a committee's point of view, although I didn't specify that. I mean, I'd have thought it would be normal practice at such an occasion like this that we would have had the Chief Executive. But anyway, I'm just making that comment. I'm going to hand over to yourselves just to give an outline of your report, and then we'll take questions from members.
Thank you, Chair, and thank you for inviting us here today. I know that we're quite over time, so I will cut down my opening remarks as much as possible, and apologies if I miss anything that I intended to say. But we will, of course, happy to clear that at the end. I will try to address some of the things that I know was said with our QA as well, proactively. So hopefully that can just focus our discussion here. So a couple of things I want to mention first, and that is that the RK was carried out reviewing a very specific purpose, and it's a pathways in response to the temporary withdrawal of emergency general surgery in South West Acute Hospital. It was not about the decision of temporary withdrawal itself, and that's a really important thing to note, and you noted that already. I also want to recognise that every statistics we talk about is a person, is a patient who has who needs care, and a patient who's very sick. Emergency general surgery patients are often quite sick patients. These are patients who require serious surgery. Even something like an appendix is actually quite serious. It's not just a bruise. It's much more. We recognise that. Our trust colleagues recognise that, and I just want to highlight that first of all. The next thing I just want to address very quickly as well is that what happened in Southwest Acute in 2022 was a collapse of a service due to staffing pressures. It is not the way to the service change. We all recognise that. That is not in line with the departmental guidance. That's not the bingo principles of changing service. The pathways were put in place very, very quickly in response to a temporary change that had to happen because staffing changes. If we have planned change, we will of course plan, the system will of course plan things better. We will of course do reviews beforehand. That's Diana, I absolutely recognise your point. That is the way it should be done. When it's temporary change, that's not always possible. However, we do think that a review post a change, whether temporary or planned, is always helpful, because we can always learn to do things better in the future. So it's good to identify did happen what we expected to happen. So if Northern Trust go ahead with the change, you mentioned Northern Trust, it'd be really helpful to know, are the assumptions right 6 months in? Or were things unexpected consequences? So one of the big system learnings from this report that RK produced to us was it's really helpful to have a review, independent review, after a temporary or permanent change of any significant size. And RK has done this very good for us at this point. The review was commissioned by the department. We wanted an independent assessment of the pathways to provide assurances about patient safety. We did not commission this review in response to particular safety concerns. We were not aware of things of patients' negative outcomes. But we wanted an independent assurance 12, 14 months in after a temporary change. And that's why we have the report we have. I'm very, very happy that RK addressed the terms of reference. There has been no change to terms of reference. It would indeed be inappropriate to do so in this kind of review. The RK is independent. On that, I also want to give assurances to the committee that the department has not sought to change the view of the RK or indeed change the contents of RK's recommendations. That is not something we would do. RK is an independent body. We want to hear the independent voice so we can respond to that. The inaccurate narrative is not helpful, and it's something we really want to stress that's not how we operate. We also want to say that we accept all recommendations. All recommendations are accepted in full. Some recommendations are easier to implement than others. That's also the reality, but we do accept that they need to be implemented. I'm not going to address the emergency general surgery situation in general in any kind of detail. Indeed, we can spend hours on that topic, and I'm quite happy to do so, probably at another time. But it's important to know that the aim that we're trying to achieve at all times is the best patient outcomes. None of us here would want to do anything that impacts patients negatively. That is something that's really, really clear. We want to see the best patient outcomes. For emergency general surgery, that means that we have the best surgeons available for patients. That is the key thing. Patients sometimes have to travel to the surgeon. That is for best patient outcomes. The delay in ambulance handovers have an impact. Academic research shows that the travel time to the right surgeon is less impactful on the patient outcomes than having the wrong surgeon. It's more important to get to the right surgeon first time. That is better for patient outcomes. And Trust colleagues can talk about some evidence around that in Western Trust specifically. That is a very quick summary of what I intended to say. And hopefully you take me in good spirit that I'm trying to make sure I give as long time as possible for questions for that. So with that, thank you. I hand over back to you, Chair.
Okay, thank you. And we're going to agree that whatever we do, it should be about best patient outcomes. So I'm glad that obviously you're going to say that, and that's accepted. I'm also glad to hear that you've accepted the RQA recommendations in full. If I could maybe ask how you're getting on with implementing those recommendations, in particular because you've heard our conversations with RQA, so all of the recommendations, how you're getting on, particular focus on the double ED weights, because that's something that's of major concern, where people are waiting in EDs twice before travel and after travel, and then also with regard to the recommendation with increasing ambulances. So particular focus on those two recommendations, but on all of them.
Of course. Just in general, on all recommendation implementation, RQA has, of course, as always when these kind of reviews happen, been updating the department on progress. So a lot of this work, we were aware of what's going to happen, and work has started well before the final publication of the report. We wouldn't sit back and wait on the publication report when we know work has to happen. But I hand over to my Trust colleagues who can talk about double weight much more confidently than I can.
Yeah, so I'm happy to pick up in terms of where we're at with the recommendations at this point. And as Breach said, she will be meeting Trust Board and we'll get it and receive an update, particularly on those recommendations. But from a Trust perspective, we've actually made very good inroads in terms of some of the recommendations that have been made. And I think we're right to recognise and acknowledge the double ED weight piece. Pre-May of last year, 24-25% of patients actually went direct to a bed in Altnagalvin, and from our perspective and from a patient experience perspective, that was not what we had wished for our patients. But in May of last year we reset our systems, and since that 79% of patients are going direct to a bed as a result of the temporary change that's been in place. But I think more fundamentally, it's really important to acknowledge as well to some of the other improvements that we've made around the clinical audit piece, which Breach talked about as well too. Ambulatory care is a new system and a new process which is directly linked to very good diagnostic services. Patients like it because they don't really want to be admitted to hospital. So with the temporary change and at the juncture of the temporary change, we had put in place ambulatory surgical assessment in South West Acute Hospital. And we also did that in Alton Galvin Hospital as well, because what that was going to help us to do was be more efficient with the resource that we actually had. Through that clinical audit work, we have developed pathways for patients now who don't necessarily need to come to Alton Galvin for their surgical care. We can book them into the overnight elective stay centre in South West Acute, and again be more efficient in terms of how we're doing and alleviate some of the pressure on Alton Galvin as well. So we've worked through that. Other presenting complaints, for example, patients with head injury who don't require surgical intervention and require a period of observation. We are working with the South West Acute team to have those patients managed in South West Acute as well. We've also developed a repatriation pathway because we recognise that a patient who has undergone surgery really will be better rehabilitated closer to their family, and it means that their family won't have to have a prolonged journey. So at the end of the acute onset of the journey, or at the end of the acute onset of surgery, we can repatriate those patients back to South West Acute to have physio, OT and the remainder of their care in their environment closer to their own home. And as I said, we've replicated that ambulatory care piece in South West Acute Hospital as well. Breach also talked about the communication and the relationship and the handover piece as well. So there is regular communication between the doctors in South West Acute and in Alton Galvin, but also there is an opportunity at the end of the day for a safety huddle as well too, which is a virtual meeting between the consultant in Alton Galvin and the team in South West Acute Hospital as well, to discuss any outstanding concerns that they've had throughout that particular day. Also important to note as well too that the surgeons, as part of their monthly review meeting as well, have a section where the emergency department consultants can actually come along as well to again look at the progress in terms of the individual pathways. Also important to note, just within the review as well, there were some recommendations around the middle grade doctors, which are the junior grade doctors working in surgery in South West Acute Hospital as well. And I'm pleased to say that all of those positions now have been filled on a permanent basis, and those doctors will rotate to Alton Galvin, and Alton Galvin doctors will rotate to South West Acute to give us more resilience in the system that we currently are working in. If I can just come back to the direct to beds piece as well too, since December 2022 to the 31st of January 25, 1,958 patients have been admitted to Alton Galvin as a result of that change in service. In ambulatory care, 1,898 patients for the same period have had their care in South West Acute Hospital. So it's really important that we build that service moving forward and with our consultants that are going to be working as part of elective overnight stay. Just to mention NIAS as well, we have an excellent working relationship with NIAS, and indeed often daily conversations with NIAS about how we can best use the resource from a private provider and from their own perspective as well. Where a patient has to stop in the emergency department, we have a process where that patient is prioritised for offload to allow that Northern Ireland ambulance vehicle back to the southern sector to be able to serve the needs of the population. So there are a number of particular pieces of work that we've taken on as a result of that RQA review and recommendations, and we report on that to Trust Board with regularity. And we report that as well to our programme board, which is overseen by our chief executive. There are also service users on that as well. I do want to pick up on the patient experience bit because obviously the insights that patients can give us in terms of the services that we deliver are key and crucial moving forward. We did engage care opinion in pre the change. But we pretty much left it to the patients to approach us with areas of concern that they may well want to do that. Since the review, we are now more purposeful in terms of actually seeking those patient experiences, and each patient will be written to who have come as a result of that pathway and be asked to provide us with information in terms of their own experiences, and that again will formulate back into reports back into Programme Board and to Trust Board. So there are a number of the actions that are well advanced, and we will report on those to RQAA when they come to Trust Board as well.
So, I mean, just for clarity, because that was very comprehensive, with regard to the double ED weights, I think you said in around May it was around 24, 28%.
Yes, 25%.
It's now 79%.
79%, yes.
Will it become 100%?
Well, that's a good question. It's a good question because
I like to ask good questions.
It's, because what we're dealing with is clinical priority of patients. So patients in Altnagalvin may well have a more significant clinical priority to require access to the bed in front of somebody in South West Acute Hospital. But that is a clinical decision which is made by the consultant or the senior doctor on the day. But as I say, we've made huge strides from that and continue to have oversight of it on a daily basis. When you break it down into the numbers, we're talking about 2.5 patients per day as a result of the change. And across the week, we're talking about 3.5 patients who don't actually go straight to a bed. But we will continue to focus on that, and we will continue to work on that as we move forward.
I mean, back to the point that Thomas made and I elaborated on about outcomes and patients, and Bridge talked about this. I mean, I don't know, I can't remember if she said Blake or Derry only, but I mean, the people of Fermanagh want to know, if they live somewhere in Fermanagh, is their outcome going to be the same as it is if they're from Derry and travelling? So, and you heard me questioning about clinical outcomes. So, whenever the report came out, both trusts, I think, in a joint response, said clearly that you've looked at outcomes. Bridge kind of said there was a bit of a gap with regard to the information provided to the RQIA. So, I mean, I'm kind of asking now with regard to clinical outcomes, 2 years since the collapse, the change, are the outcomes the same for the people of Fermanagh as they were prior to that 2 years ago?
Well, I'm going to give you quite a long answer with that. The good news is the outcomes are actually better.
Right.
So we use a company called CHKS, and what they do is they analyse admissions all across every trust in England, Wales and Northern Ireland. They look at every admission to basically thousands and thousands of admissions. They do a statistical analysis. It looks at age, sex, any comorbidities, what diagnosis you've been admitted with. They look at 260 diagnoses. And they use all of this data to generate a figure called a risk-adjusted mortality index. And what that is the number of deaths divided by the number of expected deaths. Now, effectively, 100 is your baseline. So if you have a figure of more than 100, that means there are more patients dying than you would expect. If you have a figure of less, you're doing very well. At the time of the temporary suspension, the figure for South West Acute was 110, and the figure for Altnagalvin was 85. Okay, we have looked at the figures, and we got those in approximately July or August of last year, and effectively the RAMI scores in Altnagalvin have continued to fall to the extent that if you extrapolate the data and look at average mortality rates, we now have effectively one patient surviving who wouldn't have survived every 40 days due to the change that we've made.
Thank you.
So and I think it's important to clarify as well what Bridge was saying was not knowledge of outcomes of the service, but a differential outcomes of patients within the service. And that's a big difference between those two. So we know that people have, I mean, that's mortality index. If we look at an appendix that comes out in Altnagalvin, the outcomes for patients with need appendix taken out are good in Altnagalvin. That's we know that. Those kind of data the trust has readily available. So this is Bridge comment. It's not a question of the quality of the service in Altnagalvin, and it's a very important, subtle but important distinction as well.
And just to further elaborate, we've looked at every single metrics that we can. I've looked at postcode, I've looked at GP registration. I've also had the information independently reviewed by the PHA. There is no adverse outcome for patients that live in that area. In fact, if anything, the early information shows us that the outcomes are better. And this really fits, it all comes together with the fact that if you are operated on in a centre with higher turnover, with more experienced surgeons who see something on a daily basis, you do get better outcomes. And it also fits with the review of emergency general surgery. They were effectively safety standards where they looked at all of the things you need to have on a hospital site to provide the best care.
So I'm just a wee bit confused because I mean an answer I think everybody would want to hear, but you did hear me asking Bridge and her answer to me. So I mean, I'm just concerned why she was saying she didn't get data that you're saying is extremely positive. What, can you maybe elaborate on that?
So I think some of it has to do with timings.
Okay.
When the review was carried out mostly before the summer, the mostly suspect during summer, this data was not as easily available as it is now.
It takes a while for the company to generate the data and the outcomes, because obviously it's a lot of work.
Okay, no, that's answered my question. Linda?
I'm going to follow on from what the chair has asked. So just for absolute clarity, that data that Bridge is talking about, because I accept what you're saying about the outcome for the patient who makes it to Galvin and has the surgery in a timely manner, better outcomes, and that's good. That's where we want to be. So just want to be clear about that. But can I just clarify then in terms of the data around the overall picture? That is now available and will be made available to RQIA at that meeting in April, and could be made available to us as a committee?
Absolutely. That data has been made available to our QIA, and we can certainly share it with you.
Okay.
So there's a bigger piece as well around the communication of the data, and we talked about this many times before, but these things about communication. One of the challenges with communication on very detailed data is the numbers of our patients are actually quite small. So if we break it down too far, we can't. It's difficult for us to then suddenly share the information, because the number of patients, I mean, if you're talking 2.5 patients being transferred a day, break it down by procedure, the number actually becomes identifiable. And that's a challenge for us in how do we tell this story without giving away too much. If you hope you understand what I'm trying to say.
No, I do. I'm probably still confused, and the Bridge didn't seem to think RQIA did have the actual data, but if the committee can get that data, because as the chair said, better outcomes, that is what we're all about. And then just in terms of the ambulatory increase, can we get some data around that, around what the increased capacity has been there, and what you would like to reach to actually make it a really positive picture where people are absolutely getting an ambulance when they need one in Fermanagh to make it to Galvin. Other people will want to ask questions, but I would really like if we can get that data. I'm not saying you have that sitting in front of you today, but if we can get that would be really important, I think, for our information. Chair, there's a number of other people want in, so I'm happy with it.
Collins next.
Thank you. Thank you for that information. I suppose it's fairly obvious though, isn't it? If you've got your team in Delta Galvin and you've got a struggling team in SWA, if you move all the staff onto the one site, they should be providing a better service. So I know it's good and it's a collapse of a service, so there's nothing you can do about that, but I don't think it's good news that the outcome's better, but it should be expected. But likewise, if we closed all the hospitals in Northern Ireland down and built one, as was always said to me, on stilts in Loughney with 6 roads going into each county, you'd be expecting the best of everything out of that hospital, because you would have everybody working in it. So I think that good outcome is to be expected and it's welcome. But I suppose the challenge is trying to get fundamentally the 2 sets of staff teams, one in SWA, one in Galvin, that's able to provide that outcome. That's the challenge, and it's not through management of the trust at the minute. That's down to our long-term management and how we've maybe haven't gone through transformation and we don't have the numbers of staff that we need. But in terms of the report, whenever the department issued lines from the minister on the day, he said that, and he quoted that the report did not identify immediate patient safety issues arising from the pathways. But the actual line that was in the report said that this review did not identify immediate patient safety issues during the review team site visits and a review of the documents and the limited data that's available. So is the report, has it got a second stage that it needs to go to get more data to be able to continue this, to be able to continue to find out what's happening? Because it feels like a wee bit of spin, doesn't it, there, just to give half a sentence, which is the good bit at the start, but leaving out the sort of second half of the sentence that says that there wasn't all the data available to give the determinations.
I mean, as Bridge identified, there were some data that was not readily available to RQA during the data gathering phase that now is more readily available. And that's one thing we recognize in the departmental response. But as Brish also noted, there was a lot of other things that were available. And in all that other work, RQA did not in any conversation with us say that there were any patient safety concerns that they have identified. It's not a spin. We have not identified patients having worse outcomes in any part of this review. That's what RQA has told us. Yes, there are gaps in the data. We recognize that we recognize in the response. That's what we accept the recommendations. But at no point are we aware that there are things where patients come to harm as a result. That was one of the core fundamental reasons why we asked the RQA to do the report for us in the first place. They've identified things to make sure we can monitor the things better. They identified NIAS pressures. They identified we can engage better with patients, but they did not identify patient negative outcomes. That's a fact.
I wouldn't expect them to find major issues, but I don't take the principle of what you're saying, because if there's 3 people that are alive in front of me and 3 people that are dead, and I only see the 3 people that are alive, I can clearly say with the evidence in front of me that nobody's dead. But if I turn around to the other side and then see the 3 people that are dead, I've got a different perspective. So to be able to say that just because of the data that was available, which wasn't all the data, you make a determination that there were no negative outcomes, I don't think we can with confidence say then that there might be some outcomes that are negative because we haven't seen all the data. But now it is increasing and becoming available, but it's just that emphasis on everything was grand and rosy.
Well, I mean, I don't accept that we said everything is grand and rosy, because we're accepting the 10 recommendations of the report. That's clear in acceptance that there are improvements that are required. But I mean, RQA also looked at DATEX incidents, they looked at SAIs, they looked at complaints. They didn't just look at the things, or they weren't just looking at one thing, they were looking at many things. They looked at site visits, they spoke to staff, they looked at the pathways in place, and through none of that work did identify immediate patient safety concerns. That's what RQA has told us. RQA has not told us that we think patients come to harm. We have not heard that. Not once have RQA told us that.
No, I don't think that necessarily would be the case, but it's the fact that RQA may not have found something immediate, but we can have another conversation about that. But the fact is that they actually use the language of the limited data that available, not just the data that was available, the limited data. So they have produced their report on the basis of limited data, and on their report, based on limited data, we're saying that there's nothing to see here. But I'm just saying that means by pure factual extrapolation from that, if there was only limited data available, there could be other data available that will indicate that there are problems.
Maybe just interject there, Colin. I think, to be fair, we were unable to give them all of the data that they wanted, but we gave them the vast majority. Now, some of it we couldn't do because of 2 separate computer systems. We've got a Symphony set up in Altnagelvin ED and SWIDE. They don't talk to each other. Everything has to be done manually. That is the way that it is. It's the same in every other hospital in Northern Ireland. Western Trust is no different. Once we have Encompass and Epic in place, that'll be seamless. Now, we're now 50 days away from that, so we will have better data. However, I can reassure you, we have a weekly meeting called the Rapid Review Group, and basically any staff member, from porter to consultant to nurse to junior doctor to everyone in between, to nursing staff, AHPs, can raise an issue of patient safety. It's a very simple and easy thing to do. It takes literally 2 to 3 minutes to enter. That is then reviewed on a weekly basis I chaired the meeting. There are staff from all disciplines, from all of our hospital sites, and we look at these. And on a weekly basis, if we see something we're worried about, we escalate that to an SAI. We have yet to find one single patient, even when we've done SAI investigations, where the outcome has been different for the patient due to the temporary withdrawal. And that is very, very reassuring. So if we look at that from the micro point of view, then we've also got the mortality data. Then also, if we look at the population data, there's no evidence that this has adversely affected the population in the southwest.
Well, can I welcome you saying vast majority, because there's a world of difference between you saying vast majority and a report from RQA that says limited
Yes.
I mean, they're not just close
It wa- it wa-
words.
it wasn't complete.
You know,
Wasn't complete.
it is a
We
massive
will
difference. But
set-
there is an opportunity for that to, in the next raft of information to come through, for that information to improve. The final point, just you mentioned about SIAs and the fact that there was that there were no serious adverse incidents that were found as part of that, but there were 29 adverse incidents and 4 SEAs, which is, I think, a new one, certainly on me. They're significant event audits. Is it the case that a significant event audit is the same as a level 1 part of a serious adverse incident?
It is an SEI. It's simply a lower level SEI. Now, the idea that what we want to do with a lot of these is to get answers quickly.
Yeah.
So what we would frequently do, if we get limited information and you want to know more information and you want to do it properly, especially given the oversight we have from the public and various groups, you want to investigate it properly. If you find anything, that'll then be upgraded to an SEI.
So it's important to note that these patients are really sick. There will be patients who don't have outcomes that we want them to have. Not because the services are wrong or because anything goes wrong, but because they're really sick patients. So that's why it's right to investigate, it's right to examine, it's right to explore. That doesn't mean that there was something wrong that caused the outcome in the first place. And I think we just have to recognize that as well.
Doesn't mean the other way either, does it?
No, it doesn't mean the other way either, but we can't assume just because it's a negative outcome for the patient that is because something has been wrong in the patient's care or in the system that's looked after the patient. That's two separate things. We can't assume it's right either. Absolutely.
And I suppose, Colin, again, to extrapolate on that, some patients, unfortunately, by the time they arrive in an emergency department, are destined to die.
Yeah.
And it doesn't matter what services you have on site, it's simply down to what the illness process that they have. Doesn't mean we don't investigate, though. We have to have an open mind for all of these patients to see, was there something we could have done better.
Sure, I'll leave it at maybe if we could write, maybe just to get an update, because I know I've taken up too much time. I did a freedom of information with the ambulance service, which showed that there was 97,000 upgrades of people's conditions getting worse while they waited in ambulance, and in some of the postcodes for Fermanagh it's about 5,000. Could we maybe just check if there's connections between the department and the ambulance service, because obviously some of those 5,000 could be waiting because the ambulance is up at Altnagelvin delivering people. So, but we could do that separately with the ambulance service, but on that same issue. But thank you for the answers.
Danny?
Thank you, Chair. Obviously appreciative that this has come from a service collapse point of view, and we're doing all this because of a service collapse. But it's very heartening to see that the clinical outcomes are improved. You know, that reforming a service and reorganising a service can lead to better clinical outcomes for patients. So you'd mentioned that the RAMI for SWA was 110 before. So that's when the surgical...
that was when the temporary removal of, yes,
okay,
in December of 2022.
And then Altnagelvin was 85?
Yes.
After amalgamation?
At the same time, but we continue to monitor it. We've got figures for up to 1 year afterwards. I'm looking for further 1 year figures, and it's actually continuing to fall.
What is it now?
We don't have those figures.
Less than 85?
Less than 85.
So it has continued to
Yes.
improve?
And
Despite...
again, that's probably because we've got a much bigger surgical cohort and things have centralised and our rotas are better, and you know, basically things are happening probably a lot quicker because of the number of staff that we have.
So the Review of General Surgery identified these things in the burning platform element in the start review, where General Surgery has changed massively. There's workforce challenges, there's subspecialisation, there is different patient needs, and there are really sick patients involved. The result of that means that we have many small services that it's difficult to maintain as good outcomes we want. That is the burning platform of the Review of General Surgery. That recognised in the standards that they would have to become service change. It was unfortunate that this what happened 6-7 months after the publication of that report, before we had changed to thinking of how it could be done proactively. If that is a change or reconfiguration, whatever that would look like, it's much better to have it planned. But it was clear from the Review of General Surgery that maintaining status quo of essentially 8 sites at that point was not possible with how general surgery has developed as a speciality. That was very clear in the Review of General Surgery. There had to be service change, which would lead to improved patient outcomes.
And actually, the one that you'd mentioned as well is that one patient survives every 40 days that wouldn't have.
That's extrapolating from that data.
Yeah, that's a phenomenal thing to think about. You know, the patients' lives are being saved because of this. Colin had asked a question I wanted to ask about the adverse incidents he got in. Well, one thing that did strike me when you said there's going to be better data after Encompass, it's not quite our experience here. It generally has taken months and months to get data after Encompass. It tends to slow down completely.
I think maybe going back to what you brought up when Breach was here, medication. So that's seamless. So there'll be no photocopied notes. There'll be no things handed over. We fully expect the number of patients who get an unexpected allergy. Again, that should vanish because we've now got electronic notes. It should improve patient care. I have to be honest. I'm really hopeful, although it hasn't come into the Western Trust yet.
You can't give a patient the wrong drug because you scan on the drugs, which is quite a good system as well.
And I think it's different in system level data that we're all struggling with, and the individual patient data, which would be seamless between hospitals. So at that level, it would certainly improve fairly quickly. To be able to pull the system level data will be challenging, and it is challenging. We talked about that before. That's
one last thing just before you go. You had mentioned something that I didn't quite appreciate. When somebody finishes their acute stage of their surgery in Altnagelvin, they're going to be...
There's an opportunity if their surgical journey is completed in Altnagelvin and they need more rehab, there's no need for those people to stay in Altnagelvin Hospital. They can go back to Southwest Acute and have their care.
They have their surgery.
They get over the surgery
and then they get taken back for rehab back in SWA. And they'll still be doing that at SWA. Those patients will still... be there. That's great.
An important point just to pick up as well too from what Brendan's saying about the outcomes piece. I mean, we have a very stable consultant workforce now in Altnagelvin that we probably haven't had in a number of years, both at consultant grade and at middle grade as well. There are no agency locum doctors within that workforce, which from our perspective is really positive. We've got now specialities in terms of colorectal, general surgery and upper GI, and from our perspective and for the population that we serve, that is crucial in terms of delivering the outcomes that we have for the patients in our population. So that's a really positive piece for the service.
Thank you very much.
Thanks, Danny. Dan?
That's a really great segue into the question that I was going to ask, which was there seems to be a bit of a delay between the publication of the RQIA report and some of the measures that you have implemented, which are part of the recommendations of the report. Is it possible to get that information that you gave to us in the committee? I think that would be really useful.
There is a comprehensive action plan developed by Trust as a result of the RQA review in terms of the recommendations. And I think, as a trust and as a team, we've been working on those well in advance of publication of the actual report as well too. So, excellent progress has been made in a vast majority of areas within the recommendations.
It would be really good to get that update, just sort of so that we can sort of monitor it, and because there's no doubt we'll come back to this. And Tomas, for you, I couldn't stop. So one of the things that Bree said really, really clearly was that some of these issues that are the recommendations of the RQI report and the post 6 month evaluation of change, some of those could be done. And that evaluation of change could be done before the change is made, if that is planned change. Is that going to be a principle? Can you give us a guarantee that that is going to be a principle of the department going forward?
It's very dangerous for me to give absolute promises.
But I would love that.
So can I give you as close absolute promises as I can make? I wrote to the Director of Planning Performance yesterday proposing some updates to the change to the guidance called change rules and responsibility change withdrawal of service. That would include just exactly what you're asking for: planning beforehand, having clear metrics, and a post-change review 6 months later, with a number of principles setting that out. That is what Minister has agreed to when he published departmental response. Exact details we're currently working out to make sure we word it right. That is as close promise as I can make it. I'm quite happy to come back to committee in, say, 2 to 3 months' time, because then we should have concluded that process and tell you exactly what it is we're doing. But in some shape or form, yes. The exact form we're working on to make sure we get it right to cover all areas. We want that guidance of change and withdrawal of service covers all of HSC, so all HSC bodies, healthcare and social care. We want to make sure that we word it right, that we can use it across all services, disregarding what they are for changes to be covered by this guidance. But as a principle, yes. In practice, give me a few months to work out the practical details and come back to you on that. Hopefully that's...
I hope that's not a politician's answer.
Here, you know, I tell you the truth.
Yeah.
I tell you it is.
I
I can't promise you something that I haven't completed.
No.
In principle, absolutely. The Minister has said that out in his response himself. In principle, yes. In practice, we need to work out the details exactly what it looks like.
So can I tell you just in 2 seconds, very quickly, why? Alan and I had a meeting with the Northern Trust around the issue of the proposal in Causeway to take emergency surgery to Antrim. And during that meeting it transpired that yes, we would need extra beds in Antrim, but actually we had no idea how we would create the extra beds. And that 25-26% of the beds on that particular day in November in Antrim were actually being used by people who were actually fit to go home, and we had no idea how we would actually get them home because of the lack of care packages. So we all know about these issues about flow and one particular issue having ramifications on another, and then the issue of ambulance waits to take people from Causeway potentially to Antrim, and no one could answer us on how those ambulance waits would be avoided. So I just think it's really important, if you're planning for change, that you tell people it's going to be better, but you've got to tell them that all the services are in place to make it better.
Well, I couldn't agree more. I mean, when it comes to Northern Trust, there's regular meeting between officials in the department and Northern Trust to work out exactly what it will look like, how things before any proposals are made to the Northern Trust board.
So can I assume
have
then that the delay in the Northern Trust publishing their evaluation of the consultation is due to that process?
It's whether it's delay or whether it's a process to make sure we get it right. I wouldn't necessarily use the word delay. I would use it's a process to make sure we have the right things in place so a change can happen safely. We would never support a change that we don't think it's safe and provide better outcomes for patients, because that is the core of what we do.
But I don't think any of us are arguing about better outcomes for patients. None of us, we all want the best for patients. But my argument is that there must be the proper services in place to make that possible.
And we couldn't agree more.
So far I haven't seen that, and we're playing catch up with the SWA, is the honest truth, aren't we? That's.
I mean, and that we agree with that. The department, if Northern Trust come with a proposal to make a service change, that will go to a trust board, and then we have to come to Minister for approval of the trust board's decision. Minister would not make. I mean, the recommendation Minister would not be to approve such a proposal unless those questions are answered, unless that can be shown how that would work. That's as simple as that.
Thank you. We'll revert in a couple of months.
So there's one other thing I want to pick up. It was about the implementation updates on implementation, and we heard clearly that you want to hear update how it's going. Would you want it on a regular update? It's so how frequent we can, and then we can plan for it in advance to make it easier for all of us. And that's a question back to you.
My apologies.
Every 3 months.
Every 3 months, yeah. Because then we'll plan to write to the committee every 3 months on implementation updates until we are satisfied that they're fully implemented.
Okay, thank you, Thomas, Brenton and Mark. Thank you very much. Appreciate that. It's been very useful. Thank you.
Can I make a suggestion? I don't know if Thomas's answer was a politician's answer or not, but a politician actually needs to answer it, not Thomas. I don't think Thomas can give any guarantees or make promises that aren't within his gift. So could we maybe ask the Minister that question, because this is what will give people reassurance going forward around reconciliation.
Okay, so just moving on, we're losing members here, so I have took an executive decision to cut item. No, we all agreed to cut item 8. Sorry, that was a collective decision. Well, then I've took an executive decision to cut item 9 on the agenda. It's not urgent, so we will come back to that SL1 at a later date. So we're moving then very quickly on to item number 10, which is a written briefing on hospital car parking charges. Just to remind everybody, committee previously agreed to request regular 8-week updates on progress on the new traffic management system until its full implementation. Latest update is in our pack at tab 10. There's a clerk's memo on hospital parking charges, and previous updates provided to the committee are on there as well. So everybody content to note that? Thank you. 11, departmental written briefing on children's social care review. So tab 11, page 227, is a briefing paper by the department in relation to the children's social care review. Just to remind everybody, following the departmental briefing on the fostering regulations SL1, which we heard about here, the committee requested a quarterly briefing on progress against the recommendations of the independent review of children's social care. Are everybody content to note that update? Yep. Correspondence is at, the list is at tab 12, 264. Are members content to, with the suggested actions at page 265? Just let me bring them up. Yep, everybody's content? Yep. Okay. And then forward work programme. Draft forward work programmes at tab 13, page 538. A list of all proposed visits, events and external meetings is at page 545. Can I ask everybody just to note, the next meeting is next Thursday, the 20th of March here, but because next Monday is St Patrick's Day and we're off, the Assembly staff are off, the pack will be sent tomorrow out. So,
sure. Sorry to go back to correspondence, but just it's a very quick point on the accreditation. The response that we got outlines why they haven't been able to get the accreditation, but doesn't give us a timeline as to when that accreditation might be achievable. So if we can just write to them again and ask, can they give us a timeline, and or at least give us a commitment to let us know what as soon as it is attained. So if it seems to be a long period of time, we should be concerned, I think.
okay, so dealt with that. Our packs will be out tomorrow.
Thank you.
We can read them over the weekend. Just to inform members, St Francis Hospice visit in Dublin has been confirmed for Wednesday the 2nd of April. Details will be sent out from the committee office in due course. Are members content to note the briefings set out in the forward work programme? Yep. AOB? None. So next meeting, Thursday 20th of March, 2 p.m. Thank you. Those who said I wouldn't have this meeting.
Committee Room 29, Sound.